Hello, can you hear me now?
Yes, can hear you okay.
Good morning, Trainer, and welcome to this morning's meeting. I'd like to hand over to you, please, to confirm the attendance of committee members.
Thank you very much, Chairman. Good morning, members. So prior to the start of the agenda, could I please ask members to confirm your presence when your name is called? Councillor Bill Bilton.
Here.
Thank you. Councillor Chris Brewis.
Present.
Councillor Matthew Fido.
Present.
Thank you. Councillor Mrs. Lucille Higgs.
Present.
Thank you. Councillor Mrs. Sandra Harrison.
Present.
Councillor Mrs. Rosemary Cabry-Brown.
Present.
Thank you. Councillor Rob Kendrick. Councillor Kendrick. We'll come back then. Councillor Carl Macy.
Present.
Thank you. Councillor Colin Matthews. Councillor Robin Renshaw.
Present.
Councillor Glynis Scalesi.
Present.
Thank you. Councillor Angela White.
Present.
Councillor Mark Whittington.
Present.
Councillor Stephen Woodliffe.
Present.
Thank you.
You hear me?
Yeah, Councillor Woodliffe, is that you?
Yes.
Thank you.
Thank you.
Councillor Ray Wotton.
Present.
Thank you. And Dr. Brian Wookey.
Present.
I'm just going to go back, Chairman, to see whether we have Councillor Colin Matthews.
Hello, present, Katrina.
Thank you very much. And do we have Councillor Rob Kendrick? He may join later on then, Chairman. We'll check on that one. Thank you.
Okay, thank you. Before continuing, I would like to welcome everyone who is in this appointment and listening online to the meeting of the Health Scrutiny Committee. We've already confirmed which committee members are present, and we also have present Councillor Mike Thompson, Executive Support Councillor for NHS Liaison and Community Engagement, and Cowley Chowdhury, Public Health Consultant for Lincolnshire County Council. Other participants will be introduced when we reach their item. I would like to ask you and other participants to type speak in the chat function when you wish to ask a question or make a contribution. Also, please turn off your camera and microphone when not participating. I will be asking members of the committee to turn on their camera for voting, which will be done by a show of hands. And contributions, succinct and concise, ideally no more than 2 questions per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I also want to raise that at 11 AM we will be observing a 2-minute silence for Remembrance Day. I'd now like to move to agenda item 1. Apologies for absence and replacement members. Rena.
Thank you, Chairman. Yes, we've received apologies for absence from Councillor Mrs. Suzanne Barker-Milan, and we have Councillor Mrs. Lucille Higgs as a replacement member. We've also received an apology from Councillor Sue Woolley, Executive Councillor, NHS Liaison and Community Engagement. Thank you, Chairman.
Thank you very much. And a welcome to Mrs. Councillor Lucille Higgs. We'll now move on to agenda item 2, declarations of members' interest. Do any members have any interest to declare, please? No, in which case I will move on to agenda item 3, the minutes from the 14th of October. You will find these on pages 3 to 18 of the agenda pack. I plan on taking these on block, so can I ask for a proposer and a seconder, please?
Very happy to propose, Chairman.
Thank you, Councillor Brewis. And do I have a seconder, please?
Yes, happy to second, Chairman.
Thank you, Councillor Litton. In which case, can I ask you all to please switch on your cameras and vote in favour of the minutes, please? That's by show of hands, please. Have you got those, Trina?
Sorry, I'm struggling just to see everyone on the screen.
No problem.
Have you all? Right. 8, and obviously yes. There's
Okay.
8-4. Are there any? Because obviously there'll be some not in attendance, Chairman.
Right.
Okay.
Any against, please? Any abstentions, please? No, in which case I'll take the minutes as carried, please. So if you could switch your cameras back off now, I'll move on to agenda item 4, the chairman's announcements. My announcements have been circulated with the agenda and there are supplementary announcements on 3 items. I propose to note the chairman's announcements and supplementary announcements, which does not require a vote. However, if there is any dissent, please raise now.
It was just very much, if I may, Chairman.
Yes, certainly, Councillor Lewis.
To thank you for the notes, and I do find the extra notes that are circulated to us very useful and helpful. Thank you very much.
Thank you, in which case they will have been noted. I'd now like to move into agenda item 5, integrated urgent care in Lincolnshire, which you will find on 29 to 36 of the agenda pack. I would like to welcome our presenters from Lincolnshire Community Health Services, Maz Fosh, Chief Executive, and Tracy Pilcher, Director of Nursing for Allied Health Professionals and Operations. I can hand over to you, please, for a presentation of approximately about 15 minutes, and we will take questions at the end. Thank you.
Thank you and good morning to all. Thank you for inviting us to talk about our integrated urgent care service. I thought I would start and then I will hand over to Tracy, who will do the remainder of the body of the report. I thought it'd be helpful to give you sort of an overview of some of the latest position for us as we respond to COVID-19 and how we are maximising and using our resources during this second surge. So our latest position in terms of responding to COVID positive patients, we currently have 117 as of yesterday COVID positive patients in our acute hospitals, and for us in Lincolnshire Community Health Services we have 13 COVID positive patients in our community service hospitals, and we are currently providing care for 532 patients out in the community. So that just gives you a breadth of the figures that we are responding to. The other thing that I think is really important to take into consideration is the workforce availability and how COVID is actually impacting on workforce as well, with either COVID positive staff isolating or staff being in self-isolation whilst they're waiting for a test result. So I believe yesterday that ULHT had 272 staff absence related to COVID, and for us, out of our 98 absences yesterday, 34 of those were COVID related, either COVID positive or self-isolating. So again, just gives you that flavour of the impact that COVID is having on us all. For us in the integrated urgent care service, any staff that has need to be redeployed through, they may be shielding, or we have put wraparound services of home visiting in those areas where we have had to reduce walk-in. Our staff remain within the urgent treatment service offer and are supporting either through our clinical assessment service or, as I say, home visiting. We will talk a little bit as we go through the paper. We'll give you a real flavour of our integrated offer for urgent care, but we will also touch on the temporary changes that we have had to make to our service model. These changes haven't been made lightly, but they have been made in line with the predictions of the second surge of COVID-19. And again, really clear that actually that second surge is as predicted. We have seen an increase in positive cases, particularly and of course within Lincolnshire, but it's actually going to be a more sustained as we head into our winter months. The other thing for yourselves to take consideration is how we've responded to COVID and what that's meant for us in terms of social distancing. So our urgent treatment centres don't look like urgent treatment centres as they did prior to COVID. We have had to really think about social distancing, and we have very limited seating now in order to be able to meet the requirements and guidelines. And what that means is we've introduced and really have been promoting through our 111 service of people talk before they walk first. So we're directing people along with the national campaign to talk to 111 first. That can either result in our clinical assessment service picking up that call, doing a video consultation, providing self-care or advice. We can even at that point have a bookable appointment, again, which will help us manage the flow of patients waiting in a very limited space. Or we can offer a home visiting service. So we're really promoting our Talk Before You Walk campaign for the population of Lincolnshire. Tracy will then talk a little bit about the integrated clinical assessment service, and this is fully wrapped around our urgent treatment centres. And we've been working really hard since wave 1 of COVID and throughout the summer to implement as many solutions as possible. So the Talk Before You Walk campaign, but also some digital enablers as well, such as our e-prescribing. So we have the ability to be able to hear and treat or see and treat from either a telephone call or a digital platform, and then we can actually then send a prescription to your local pharmacy for prescription. So again, reducing that requirement of social interaction. And I'm really delighted to say that 86 of all our patients that come through from 111 are actually seen through this method. So again, it's really proving to be a worthwhile first step for people to take. And then in line with, just finally from me before I hand over to Tracy, in line with the changes that we have had to make, they are in line with a very strong national picture of how people are being asked to still interact with their local NHS, but first by using 111, and again to ensure that we in those areas that we have had to reduce walk-in activity, particularly Louth and Skegness, which is open till 10 p.m. at night, and we have fully wrapped around a home visiting service for those patients. So at that point, I'm going to pause and I will hand over to Tracy to take you through the body of the paper. Thank you.
Thank you, Miles.
Okay, good morning, everybody. Thank you. So I think somebody wants... Did you want me to stop, or are you happy if I continue?
If you could continue, please, for the time, or we'll take the questions at the end.
Okay. So as Maz has described some of the integrated urgent care services, so following on from our visit to the Health Scrutiny Committee in July, what we have done is just added some more information, particularly focusing on integrated urgent care and our clinical assessment service. So as described by Maz, when a patient phones 111, if they are deemed to require a clinical assessment, that call is passed through from 111 into our clinical assessment service. And we are still seeing quite a significant number of patients coming through that mechanism. So through 111, through into clinical assessment, and then on to our kind of clinical assessment service. During the week, we're seeing about 180 to 200 patients a day, but at weekends we do know that service becomes busier, and at weekends we're seeing on an average of about 450 patients coming through clinical assessment, and the majority of those, as I described, come through the 111 telephone, but at about 85%, with about 9% now coming through 111 online. So we can see that shift in the population using 111 online, and then about 9.5% of patients coming through other mechanisms. So you can come directly through into our clinical assessment service, and that's for care homes. So we have the CAS for care homes, as we describe it, where care homes can phone through to clinical assessment and have immediate advice and support through that mechanism. The outcomes for patients are really positive. So 85% of patients are diverted away from ED. So we're able to close 66% of cases directly through clinical assessment and the advice and guidance and advice through our own clinical assessment service. And then about 12% of patients are booked into a UTC, so one of our urgent treatment centres, for an appointment, and about 7% of patients are diverted or identified need to go to A&E. So there's a range of different outcomes for patients, but primarily 66% of patients were able to give immediate advice, support and treatment with no ongoing need for any further treatment. So it's quite busy in clinical assessment still, and as we talked about previously, we did see that activity increase in March as obviously COVID first wave hit us, and we're seeing that increase in activity. We would normally expect to see an increase in activity over winter, and again, I think that's the profile that we are seeing at this moment in time. When I move on to our urgent treatment centres, what we've provided is a range of information around the urgent treatment centres and what we're looking at. So the really positive is 98% of patients that move into our urgent treatment centres are seen, assessed, diagnosed, managed within that 4-hour target. And then what we also make sure that we do is do that immediate clinical assessment of the patient. So again, 90% of patients have that immediate clinical assessment within 15 minutes. Now, if they're deemed to need an urgent kind of advice and diagnosis, then they will move very quickly to be seen by the appropriate level of practitioner. Otherwise, we will see patients kind of, again, triage and see patients in order of priority. For our urgent treatment centres, we have a blended model across Lincolnshire. So the two that are at Boston and Lincoln are called integrated urgent treatment centres. So they are co-located across that front door with the A&E department and also with SDEC, so same day emergency care. So when we start talking about 111 first, that's about being able to book patients into a range of urgent treatment centres or into the same day emergency care service. So there are different ways of managing patients, and that's been part of that integrated service. That still continues to be 24 hours a day, 7 days a week, and with that clinical navigation focusing on making sure that we can move patients into our urgent treatment centres as much as possible. And if we look at Lincoln and Pilgrim, we can see about 50% of patients that walk into those services are then moved at Lincoln into urgent treatment, and it's about 36% at Pilgrim. So really high numbers of patients that we're managing through those pathways. Grantham became an urgent treatment centre as part of COVID response across Lincolnshire, and again that operates 24 hours a day, 7 days a week, with the ability to do video consultation and also to do the kind of booked appointment process as well. So a range of services, and again really good response from the public across Grantham, and really pleased to see the activity in those services increasing over the point of time. Then at Louth and Skegness, as Maz described, as part of COVID response, and this was on the back of our peripheral kind of sites for urgent treatment centres had seen quite a significant reduction in activity within the first wave. So we took the decision to change the profile of how those urgent treatment centres work so that we could provide more clinical assessment service and more home visiting capability across Lincolnshire. So those two services still operate with clinical assessment, home visiting 24/7, but walk-in stops at 10 o'clock at night. But if patients do phone 111 and are assessed by our clinical assessment service, they can do booked appointments, so they can book them into the urgent treatment centres the following day. Spalding is one of our MIUs, so that again saw very low numbers of patients accessing that service in the original wave of COVID. So we took the decision to temporarily close that service again, making sure that we could utilise those staff in a way that we could meet the needs of the local population. So those staff have moved into clinical assessment and home visiting service or into the urgent treatment centre at Pilgrim. Whilst we'd had temporarily closed Gainsborough as part of our restore programme within LCHS, we restored Gainsborough MIU and then have upgraded that to be a UTC, so an urgent treatment centre, and again has exactly the same capability as the other urgent treatment centres, and it's open 12 hours a day, 7 days a week. I'll stop there.
Thank you, Tracy. That's very helpful. We'll move to our questions now. First of all, I've got Councillor Whittington, please.
Thank you, Mr. Chairman, and thanks, Howes and Tracy, for the report and the presentation. I want to base my question really is around the UTC at Grantham Hospital. Now, obviously, it's currently a transitional arrangement due to the pandemic, and obviously it's gone from a part-time A&E to a sort of full-time UTC, and obviously for the duration of the pandemic. And of course, it's welcome news this week that potentially that we could be onto a vaccine, hopefully being rolled out before Christmas, which I think would be great for everybody actually to maybe start to see some return towards normality at some point in 2021. I'm presuming, if you can confirm this, that once we're out of the pandemic and we are back to normal, whatever normal is going to look like, that it would the plan be to then revert back from the 24/7 UTC back to the sort of the state anti the lockdown to the sort of reduced hours A&E at Grantham? That'll be my first question. The second question then relates to staffing issues, because presumably at the moment you're able to staff a UTC at Grantham 24/7 with a certain level of staff, and I'm presuming that some of those staff are going to be nursing staff and some are going to be medical staff. And you also mentioned, I think it was Tracy mentioned in a presentation, that you've been making use of video consultations. And actually, I think what's come out of COVID for an awful lot of people is increasing use of technology. I guess the purpose of my question is, how many extra staff would it take? Or could you use the same level of staff you've currently got providing a UTC 24/7 to providing an A&E 24/7 at Grantham if you make use of video conferencing with consultants and having medical staff available online? Because actually, one of the issues that we've sort of got at Grantham is the inability to physically seems to have enough of the sort of the middle grade and consultant level medical staff at Grantham Hospital, but doesn't technology offer us the potential to actually cover that by having senior staff available on call if required? So some understanding around that, because I think it's really important for the people of Grantham potentially to sort of understand if you can sort of do a UTC 24/7, what would it take to do an A&E 24/7 if we could use modern technology to in effect fill the gap in medical staff? Thanks.
Thank you. Shall I respond to the first part, Tracy, and then hand back to you for the staffing, the differences between a UTC and an A&E staffing ratio. So in terms of Grantham, it was a decision taken by United Lincolnshire Hospitals NHS Trust, and we have been asked to provide this temporary service until the 31st of March in response to us preparing as a system for COVID. So in terms of from an LCHS perspective, we are in a position to continue to provide this until the 31st of March, unless, of course, they have to convert the Grantham site back from being a green site and reenact. So from our perspective, we see this as a service that is being delivered under the COVID on a temporary measure at this moment in time. Tracy, can I hand to you in relation to the differences between the staffing and what's required for an A&E and urgent care, please?
Yeah, thanks, Hugh. So there are some fundamental differences between an urgent treatment centre and an A&E department. A&E departments operate under what we call the Royal College of Emergency Medicine standards, and they have standards for how many consultants are required, depending on the size of the department, and then obviously the other elements of treatment in that site. So I think for Grantham, the workforce profile for a UTC versus an A&E is quite significantly different, and then how the practitioners operate. So within a UTC environment, what we primarily focus on is it's a GP-led service, and it has urgent care practitioners, advanced care practitioners that see, treat and manage those patients autonomously. Within an A&E department, you'll have a range of different nursing, medical, other staff working in that department, but they have very different skill sets. And I think one of the things that we have very much focused on is, whilst when we moved into this temporary management at Grantham, the majority of the staff that worked in the A&E department have remained, and we've been working with them in terms of developing some of those skills around urgent treatment centre. But actually, they have got a different skill set and a different competency level. So we've supplemented some of those staff with our own urgent care practitioners. The UTC at Grantham is very much focused on that immediate management and treatment of patients and trying to maintain that local population. So in that footprint, we also have mental health liaison, we also have the AIR team, which is our assertive in-reach team, and they're also the diagnostics, so the same day x-ray and GP referrals kind of all move into that same area. So it's kind of the blue bubble as they describe it at Grantham. To deliver a 24/7 A&E department at Grantham is a very different model of care versus a UTC, because primarily what we're looking at is that integrated service. So the clinical assessment service works as part of the UTC. The clinical assessment service and the video consultation is part of a UTC offer. Now, as whilst we're working on 111 first to be part of that integrated kind of ability to book in patients, that's very different to an A&E. An A&E department is where you immediately need to see and treat a patient in an A&E department, whereas a UTC is an integrated service that works with a local population and some of those local pathways of care. So another practitioner that we've brought into our clinical assessment service are AHPs, because again, sometimes they have a skill set and a level of knowledge about patients and how we can maintain that patient at home, which is different to what a nurse or a medical practitioner might focus on.
Thanks. If possible, Mr. Chairman, could I ask supplementary? You
may indeed, yes.
Thanks. I mean, the purpose of my question really was to see, and I don't think it was answered, was the use of modern technology to kind of bridge some of these gaps. Because, you know, I'm an accountant. During COVID, I now hold meetings online with clients and various things. We've got an awful lot of our merchant banks, our large financial institutions are working from home. We now have virtual courts where the legal profession are managing to work in a virtual environment. We're having these virtual meetings so the political democratic process can carry on. The House of Commons and having the ability for people to dial in. I'm just wondering why it's so different to the medical profession in terms of using modern technology to actually improve and develop services where it may not be possible physically to have people in attendance. Because I can't. I'm struggling if certain professional groups are finding ways around or finding workarounds around this. What's so special about the medical profession? Thanks.
Shall I? So I think you're absolutely right. We've used digital technology very differently. So we have got a lot of digital technology and it is brilliant for connecting people. But what you can't do under a digital technology is actually feel somebody and do some of that physical assessment. So where we would within a UTC be able to look at something, or in a kind of clinical assessment service, we might say, I would like to have a look at how you're walking or look at a rash. What it won't enable you to do is put your hands on a patient and do that actual physical assessment. And I think for an A&E department, primarily where patients are attending because they have an immediate or life-threatening condition that needs urgent and immediate response, it's more difficult to use digital technology to do that. So you'll be able to talk to a patient, you'll be able to do the history. So, and again, it's a really important part of the physical assessment is finding out the history from the patient. But actually what you won't be able to do through digital technology is actually do the physical examination. And certainly for a number of patients that are attending A&E, they are attending because they have an immediate life-threatening condition that needs that level of detailed physical examination. And some of the radiological, so those diagnostic interventions, so the ability to look at an X-ray, an MRI, some of the other CT scans, be able to look at bloods to see what's actually happening for our patient immediately. So it's a very different type of intervention that we would be doing in an A&E department. And I absolutely agree with you. There's lots of things we can use technology for, and I think we have really taken that opportunity. But there are some things you actually do have to physically examine a patient for.
I'm not entirely convinced, I have to say, because modern technology, you should be able surely to look at the results of blood tests on a computer that's been done in one location, available in another location, and the same with X-rays and other things like that. And we're actually in a situation now where GPs are actually encouraging people to have virtual consultations. I have to say, I'm struggling, and I remain somewhat unconvinced, but thank you anyway. Thank you. Thanks, Mr. Chairman.
Kelly, would you like to comment at this point?
Yes, I just wanted to add that for those patients who attend A&E, they are, as Tracy mentioned, they're sicker than those who attend an UTC center. Also, the facilities required for A&E are more specialized in the sense that you need resuscitation facilities if somebody is having a cardiac arrest. And also the skill set is completely different. They're more highly skilled in the sense that if you need any vascular access, you'll be able to put those in. So the skill set is different, and you can't have those done virtually.
Okay, thank you, Kelly. Maz, you'd like to come in? You're on mute, Maz.
My apologies. Thank you for that. I think the key thing is Tracy was responding to the question in relation to an A&E. In terms of the NHS and digital, I can absolutely assure you we have GP Connect, which is being used over 5,000 times a day. We use digital platforms for self-care and particularly within the community and for outpatients. So we really have embraced technology. There was work being done pre-COVID, but COVID, I absolutely agree, has accelerated. In addition to some of your questions about blood results, etc. We are testing different parts of technology. We do have a local healthcare record, our care portal, which absolutely enables that transmission of information of patient record. So there is lots of things that are being done. Tracy was responding to that A&E environment, so thank you.
Okay, thank you. I'd like to ask a question building on from Councillor Whittington's. Clearly it's a changing picture daily at the moment in time. However, I saw that there was a news story stating Grantham Hospital will struggle to remain a COVID-free site due to the increase in coronavirus cases, which came directly from ULHT. How might any changes affect the UTC?
Okay, so there are trigger points that ULHT have in place. So as you know, the green site was developed so that we could continue to deliver, cancer and some of that green site urgent surgical. So it's been a really great part of our system. But if we become overwhelmed, as in we need greater numbers of beds than we have available for emergency cases across Lincolnshire, then that's the point about the triggers for when Grantham stops being a green site. At the point that Grantham stops being a green site, we revert back to the previous arrangement around an A&E and an out-of-hours service. So that will be really a decision made at system level around the internal triggers for ULHT in terms of their numbers of COVID patients and the numbers of beds that they need to be able to treat those patients safely across Pilgrim and Lincoln. And then the rest of the system will need to respond to that in terms of what services then go back into Grantham to deliver an A&E service.
And with the circumstances changing, obviously, as I say, on a daily basis, how quickly would you move back to an A&E in that circumstance?
I think that's for ULHT to be able to answer that question. Clearly, if it reverts back into an A&E department, then it will be for ULHT to deliver that A&E department. That's not part of our CHS's portfolio of services.
Right, okay, thank you for that. In which case, I've now got a question, please, for Councillor Brewis.
Thank you, Chairman, and I thank them both for the report. And we know we're in a difficult time, and this is not this is not item 7, this is item 5. And we also know there's a huge problem with availability nationally, with availability of medical staff not held by the number who are leaving to go back to their home countries before 1st of January. It's a very peculiar situation we're in. But my real problem concerns what is said initially on page 36 about the Spalding area, i.e. South Holland. Now, there are between 85 and 90,000 people in South Holland who are in effect being told to go elsewhere. Now, because of the pure location of Boston Hospital, if anyone was in Spalding and they needed an urgent treatment, because of public transport, I would expect them, even from Spalding, to go to Peterborough or Lynn because of the locations of the hospital, which are so convenient for public transport, and how that helps Lincolnshire's health service, even in these times when you're saying to people, well, go out of county. That affects the funding to Lincolnshire. I'm a long way away. I wouldn't dream of going Boston for anything because it's so far away. But if someone needs public transport, from Spalding it's a 3.5-hour round trip. From Sutton Bridge or Long Sutton, it's a 6-hour round trip. So what I really want to know is, when are we going to have a detailed report and progress on how this enormous hole in the UTC provision within Lincolnshire for the whole of South Holland will be addressed properly as soon as possible? Thank you, Jim.
Do you want me to come in here?
That'd be helpful, thank you, Miles.
Yeah, so in terms of commissioning of services, that would be to be the Lincolnshire CCG that would take that forward. In terms of the services that you talked about, if you are needing emergency care, I would say we wouldn't be putting anybody on public transport for emergency care.
Sorry, I with respect, I didn't say emergency care. I said anyone who wants to attend a UTC.
In terms of where we are doing home visiting. So I think Tracy alluded to that in her report. We're asking people to phone 111, and we're actually going to people's homes in order to deliver that service. Tracy, is there anything else that you would like to come in there in relation to that service and maybe talk about Peterborough?
Yeah. So yeah, I think going back to the reason we took the decision to change the way that the services were being offered, because we weren't having people attend that MIU. So we were having an MIU at Spalding Hospital where prior to making the decision, we were seeing approximately maybe 4 patients a day walking into that service compared to, normally prior to COVID, 30, maybe 40 patients a day. So it was actually, the decision was made because of that point. It wasn't made because we were seeing lots of patients coming in. We were actually seeing very few patients, and we took the decision to change the way that service was being delivered so that we could maximise the utilisation of that staff and make sure we were still able to meet the needs of those patients. We've continued since then to monitor postcodes, so monitor where patients are treated or going for treatment, and we would always focus on trying to, wherever possible, treat that patient through home visiting. We have looked at restoring that service, Councillor Brewis, but the main reason that we haven't is because actually at this moment in time, there is not a profile that's telling us that there is a significant issue for that local population in accessing services. So I think there is a point around, and we've seen that with Gainsborough, we've restored Gainsborough as very similar points that you've made about the population. It was moved into a UTC because the decision had been made that they would become a UTC. What we're also looking at is the same conversation for Spalding. So it's not that we're, resisting restoring Spalding to a service, but it's understanding what that service model needs to look like to meet the needs of that local population.
If I may briefly come back, Chairman, I thank for the answer. It doesn't really answer what I said, which is when you are going to bring us a detailed report on when the southeastern quarter of Lincolnshire will have an urgent treatment centre and the minor injuries unit. I'm not surprised that the use has dropped, because people have suddenly found, for what they used to come in, which were grazes and scratches and little bruises and things, they deal with them at home like we always did in our childhood. And it's a very rare thing for me to say I am absolutely totally dissatisfied with the answer, and the people of South Holland are not at all happy about it, having to cart off out of region, which will carry on. And I haven't had an answer to when are we going to have a detailed report on when Spalding will have a proper UTC provision in the future. I'm not talking about during this particular crisis. Thank you. If I can have an answer.
Okay, Councillor Bruce, I think Maz alluded to, it's not our decision to make, so I'm not trying to dodge the question. It's not our decision to make, it's a commissioning decision about the model of care. So it would be for the commissioners to identify that UTC and the detailed report about a UTC for Spalding.
I accept that, but you have reported on it, and I'm not happy, and I want to make sure I lodge the word now that we are extremely dissatisfied. Thank you. I'll leave it at that, Chairman. Thank you.
Thank you, Councillor Brewis. I think that might be something that would be worthwhile considering under the work programme as well later on. So we'll look at that at that point. In which case, I'd now like to bring in Councillor Wootton, please.
Thank you very much indeed, Mr. Chairman. Maz, if you remember the last meeting, you reported to us there was an 8% increase in the numbers of people using Grantham UTC. And I asked you, was that due to people who couldn't get doctor's appointments, GP appointments? And you didn't give me a real answer on that. But I did actually publish it on Facebook, and I had a flurry of comments back from people saying, yes, they did use the UTC because they couldn't get a GP appointment and they liked a face-to-face meeting with a professional. But the problem that occurred is that when they went to the UTC, they were stopped by the security guard again from trying to get in. And I wondered, has that message got to the security guard that it is a 24/7 walk-in service with no appointment?
Thank you for your question, and I am aware of the incident that you're talking to. It was a ULHT security guard who was probably a bit overzealous in taking their responsibilities of COVID, and that was picked up as soon as that was notified. Andrew and his team did ensure that did stop, so I can give you that assurance.
Good. On the positive side, though, Maz, there's been some real positive thanks to me about the excellent service that they've received at Grantham Hospital, and the fact that you've got a 98% turnaround in people is really good. So thank you for that.
Thank you.
Thank you, Chairman.
Thank you, Councillor Woodson. In which case now I have Councillor Woodliff, please.
Thank you, Chairman. Trying to get on.
You're on.
Can you see me now?
We can,
Thank
yes.
you. Thank you. It's about your neck of the woods and I suppose mine, really. I'm very concerned about what's going on at Skegness. I know we've got an agenda item 8 later on, but don't really quite understand the situation as has been explained for Skegness, because we talk about a UTC has been an integrated service for the local population, but of course in Skegness, not between 10 p.m. and 8 a.m. Now, I'm very concerned about this because the East Coast is a very isolated area. And we're not just talking about Skegness, the town, we're talking about the periphery around the outside, which probably could regard itself as being Skegness, places like Wrangell and so on, which are closer to Skeg than perhaps to Boston. You know, there's very, very poor infrastructure in this area. The roads are not good. The internet is pretty diabolical in places. Even mobile phones don't work very well. So the idea that you can, offset an urgent treatment centre for, should we say, internet or phone connections, I think is very questionable. I feel that I'm very concerned about the fact that many people now almost live permanently in caravans and other accommodation on the East Coast. So the facilities that are being offered, I don't think are good enough. So perhaps Tracy could, explain why it is that Skegness is, and the area around that is receiving such a second-rate service, basically, because the area itself is not receiving the same level of expertise, I would say, as if you lived in Grantham, or if you lived in, say, Lincoln, or if you lived in, say, down in Councillor Bruce's neck of the woods down there. Councillor Bruce has the benefit of Peterborough Hospital and King's Lynn Hospital and a bus service. What's a bus, by the way? I mean, it's all questionable. So I think we need. I know it's the agenda item 8. It comes up later on, but I am very concerned about this. So perhaps Tracy, perhaps fill us in on how, for instance, how many visits occur, how many home visits are occurring each day, for instance, as an example. Can I leave it at that?
Okay, so the point you were making around the actual service, as I said earlier, one of the reasons we took the decision is because we were seeing very few patients walking into the UTC at any of our standalone UTC centres. So the change to the opening hours was in response to that, and actually prior to COVID, so for the last year, if you look at the activity profiles both at Skegness and at Louth, we were seeing very few walk-in patients overnight. And I think what we were trying to do is focus on, if you become unwell overnight and you phone 111 and our clinical assessment service feels that you need to be seen, actually what we would rather do is come out and see you rather than bring you into a UTC, because it might not have all of the facilities that we need to treat you. So that very much clinical triage process, which is through clinical assessment service, is trying to understand what your needs are and then how do we best meet those. So rather than people having to walk into a service to ask, what are your needs, what we're trying to do is do that initial clinical assessment service process and then signpost you into services. So if you are well enough to be able to drive to a UTC, then we can look at the availability of those UTCs, where they are. But it is trying to support the patients and the population to access the right service first time, because sometimes you may go into a UTC, but actually we don't have the facilities to care for you, and therefore we're delaying your treatment because we're then having to assess you and potentially then wait for an ambulance to transfer you to an A&E department. So again, what we're trying to do is make sure we signpost and manage patients in the most appropriate place depending on their individual condition. So the clinical assessment service isn't there as a mechanism of trying to delay treatment. Actually, it's there to try and make sure, as we described, 66% of patients don't need any ongoing treatment. And if they do need ongoing treatment, then we can either book them into one of our UTCs, or we can signpost them onto an ED. And I understand, the concerns that you have about that walk-in option, but actually getting up in the middle of the night feeling unwell, what we're trying to say is we'll phone our clinical assessment service through 111 and we'll be able to identify. Sometimes we phone 999 and we immediately dispatch an ambulance to that person as well. So those are a range of options that our clinical assessment practitioners, and they are qualified practitioners, and we do have GPs doing clinical assessment as well. So there's a range of people that are doing clinical assessment. And again, depending on the condition of that patient, we will then allocate the appropriate practitioner to be able to assess the patient as well. So from a kind of treatment perspective, that's the reason that we changed that, because partly we were not having pre-COVID patients coming in overnight and walking into the service. And then if they were walking into the service at times, we were then looking at those different treatment options.
Fine. Mr. Chairman?
Yes.
Yeah. I'm sure you'll have a few comments to make on this, so I won't take your thunder on it. But you didn't actually answer the question, Tracy, about how many visits are occurring each day? How many visits are occurring each day?
So we have home visiting across, I'm just going through our report to get that. We have home visiting across the county, and they are working out of a number of bases. For specific in the Skegness area, I'll have to find that information and provide that.
You can email me. Email me. Okay, that's fine. Yeah. Fine. Thank you, Chairman. It's over to you now. Thank you, Chairman.
Yeah, thank you, Councillor Woodliff. Just building upon what Councillor Woodliff's had to say, it's quite clear at the moment in time that if you know that the urgent treatment centre is closed in, say, Skegness or Louth, you're going to go to one of two places. You're going to go to either Pilgrim Hospital or you're going to go up to Grimsby. And the fact of the matter is, I think that the figures are somewhat skewed on that basis. Not everyone will use 111. There's a lot of distrust in 111, I find, from residents. And so it would be very interesting to know what sort of figures are actually being displaced. And what makes it worse in my mind is the fact that if they are going somewhere like Pilgrim or Lincoln or Grimsby, they are much more likely to come in contact with people who have got the COVID illness, and that can cause further problems. So I would like to know what those figures are, much along the same lines as Councillor Woodley.
Okay. So we have looked in detail at postcode analysis. So as part of the changes that we've made, we've looked at exactly that point, Councillor Macy, in terms of postcode analysis of where patients are accessing treatment and if that's changed at all with the changes that we've made. And we can't find a variation at this moment in time. There are not significant numbers of patients either accessing the services at Pilgrim or at Grimsby. We continue to monitor those postcodes. So we do monitor postcodes at people accessing other services, as well as looking at the profile of activity within our own services. So it's something we really are very focused on and sensitive to. And that is, again, one of our triggers, because for the very reason that you've identified, actually, we would want patients to be treated as close to home as possible. And if a patient needs a booked appointment or an X-ray or another diagnostic intervention, we can book them into that from our clinical assessment service. I think Maz might want to add to that.
Yeah, okay, thank you, Maz.
Yes, thank you, Tracy. And it was just to say you're absolutely right. We are trying to encourage people to phone 111 first rather than turning up for the very reasons that you've highlighted, Councillor Macy. We're trying to do this in order to really protect the population as best as we can, but also provide care close to home. And I think in terms of if we're able to have a telephone triage with somebody that can either do self-care, book an appointment, or we do a home visit, that is a much more safe and sensible way of dealing as we are continuing to respond to COVID in a second stage, in a second wave, which we are seeing is going to be much more sustained and have more COVID positive patients.
Okay, thank you. I do have further questions, but I'll wait until my other speakers have come forward. So, Councillor Kendrick next, please.
Thank you, Chairman. I was just interested looking at the figures for the reduction in attendances in March, as the pandemic hit us. And it does strike me as to how many of those attendances may not have been essential, but people just thought, I'll go down because I've got a slight problem and I'll get somebody to look at it. I was just wondering, particularly in view of the fact that people have had problems with GP attendance and getting GP appointments, you would have thought they might have gone up if they couldn't get to their GPs. So it seems the reverse seems to have happened there. I was just wondering whether any research has been done as to why there's been a tremendous drop-off. I may have missed something in the report, but I was just wondering, because it's very significant. Thank you, Chairman.
You want me to answer that? Yeah. So you're absolutely right. I think what we expected as part of COVID Surge 1 was an increase in attendances across our urgent care services. So that's what we'd planned for, and that's one of our surge plans as an organisation. But what we saw was something very different, and there is something about that. What we saw was something very different, and also as we've been monitoring our activity profiles across all of our urgent care services, what we've seen is that continued trend, and that hasn't changed in kind of over the summer and now moving back into second surge. In terms of research, obviously, what we do is monitor what people are attending for, and we also monitor to see what the outcomes of that visit is. So for some patients, it is advice and guidance that they are walking into the UTC for, which we, from our perspective, we're now giving through the clinical assessment service and online. So people have got very used to now, I think, accessing the digital platforms that we have available in a way that they probably weren't prior to COVID. It's been one of our ambitions as part of the health service is to support patients to use digital platforms over the course of the last few years. But actually, we've seen a complete change in the population's access of those services. So some of that reduction is because people are utilising those mechanisms now and are then having advice and guidance through either video or telephone consultations that previously they would have walked into a UTC for. I think the other thing Maz talked about is our prescription, our ability to prescribe through our clinical assessment service now as well, digital prescriptions that can then be delivered to local pharmacists. Some of the patients that were going to UTCs previously were going for repeat prescriptions because they weren't able to access those in a timely way. So again, some of this is the way that we're delivering the service is very different. So people that were using UTCs or our urgent care services for those activities have now started to use some of the digital ways of accessing those services.
Ms. Tim, I think that's very interesting, although I know some commentators have remarked on the possibility that some conditions are not being treated because people are afraid, as it were, because of COVID, to actually seek any advice and help. And that might be an unintended consequence of the pandemic, is non-COVID related conditions actually causing serious problems for people in the future. So it seems to be you can't win either way on this one. Thank you, Chairman.
Thank you. Maz, you'd like to come in?
I was just going to say that exact phrase. We have some patients who, when we do speak to them on the clinical assessment and we ask them to come in and see us, are really, really.
I seem to have lost Maz for the moment in time.
Yeah, I could, yes.
Oh, she's back. Hi, Maz. We lost you for a moment.
Oh, did you miss all of that?
We did. Sorry.
Yeah, somehow I've seemed to have a power. One of my computers have gone off. Can you hear me now?
We can hear you now.
Yeah.
That's fine.
Yeah, I was just going to say we have that very situation playing out. We have some who continue to want to just attend, but we do have others when we have spoken to them on our clinical assessment service, and we've suggested that we do need to see them in order to treat them. They've been very apprehensive. So, you know, we continue to, and you'll see the national campaigns, the Just campaigns, really encouraging people to continue to make appointments with their general practitioners. Thank you.
Thank you, Chairman.
Thank you, Az. I'm just conscious of the time. It's now just about to turn 10:59, and at 11 a.m. we will be observing the 2-minute silence. So I don't want to take any more questions for the moment for it to go over. So as soon as it reaches 11 a.m, we will hold the 2-minute silence, and then I will go back to the list of speakers. Okay, thank you all. It's 11:02 now, so thank you for observing that. We'll move back to our list of questions. I have 2 more speakers and I will be closing down the debate at this point. I'd like to bring in Councillor Matthews, please.
Thank you, Carl. I just want to share my concerns about Skegness Urgent Treatment Centre. I was there on Monday. I had to go for an X-ray. Actually, it's unbelievably difficult to get conventional National Health Service treatment. I had to email my GP. I had to have an online conversation about my knee, and all I could say was it hurt. It needs fiddling with. But nobody would see me or could see me. They referred me to an X-ray at Skegness, and I went for an X-ray, and it was like the wreck of the Hesperus. There were more staff there than anybody. I was the only patient in the whole hospital. The staff were cleaning, doing stuff, looking industrious. The wards were all empty. And I had to feel then that actually this is a self-fulfilling prophecy. If you say you're closed and then close yourself and then say you should go to other places, the hospital will become an irrelevance because no one's going. And then you state the statistics. You're saying we only had 4 walk-in people. Well, you only have 4 walk-in people because to all intents and purposes, you have closed it. And it is a travesty. It's awful because it's 15 miles for me to go to Skegness one way and 15 miles for me to go to Louth the other way. And that's in exactly the same boat. Or it's 34 miles to go to Boston or 43 miles to go to Lincoln, which is a bit of a nuisance when you can't drive because you've got a bad knee and someone has to take you. So I'm sorry, it sounds like a rant, but I actually feel we are being manipulated here by the powers that be because you're saying there are no customers because you have closed the facility. It almost appeared mothballed on Monday. The staff I spoke to were very nice. Everything was fine, but it's not operating as an urgent treatment centre and it is not promoting itself to be open for business. It is being closed down by stealth. Thank you.
So may I come in there to start off with, and then Tracy can pick up if there's anything that I've missed. I'm sorry that you felt that way. That is absolutely not the case at all. This is not being closed by stealth at all. This is about we are responding to a global pandemic, and in relation to vibrant hubs at the moment, I will be very honest with you, we are limiting patient visiting for the very reasons of COVID. We are managing very difficult circumstances at the moment of outbreak management of COVID. We don't want to see that across our acute or community hospitals for the very reason we will have staff increased sickness, patient increased COVID cases, and we've got to manage that the best way possible. In terms of the urgent treatment centre, it is not closed for business. We are encouraging people as best as possible to phone first in order to make that a bookable appointment. So, you know, we haven't closed our doors to anybody, but we are encouraging people to actually stay safe, and I make no apologies for that. At a time of significant increase of COVID in the community. Tracy, is there anything you want to come into that I haven't covered that you think would be helpful?
Yeah, I mean, I think in terms of that point, you will see staff cleaning. You will see staff look at, you know, making sure that the environment is clean. We are very focused on making sure that our environments are safe for people to access. I think the point around the numbers of people accessing that service, clearly the urgent treatment centre is open for walk-in. It's open from 8 o'clock in the morning till 10 o'clock at night. There are a range of staff there, and I was at urgent treatment centre at Skegness a few weeks ago as well, and they were seeing quite a vibrant number of patients, but they are having to socially distance. They're having to manage patients so that they have that waiting area. So we have 2 waiting areas for staff, for patients. And from a ward perspective, the 2 wards are open at Skegness. One is currently under health protection around, we have got an outbreak. So again, as Maz describes, when we go into outbreak management, we do limit the number of visitors that can go into that ward. And obviously the staff have to remain working in that area rather than working across Skegness. So Skegness Hospital itself has had to adapt to COVID and had to make sure that the environment that we're caring for patients in it is COVID secure and COVID safe, and that's absolutely part of our role as a provider. We are very focused on making sure Skegness is that vibrant community hub. We want it to be that local hub for the access for local services for the population of Skegness, and that is very much a focus for the future around Skegness. And how do we ensure that those services are designed to meet that local population need? For the very reason you described, it is a rural place. The road infrastructure and the transport infrastructure means that people struggle to access services, which is why we keep talking about we'll bring services to you. We've got community nursing, again, operating in that area. We have our integrated community teams, our physiotherapy, our OT. Obviously, if you need a radiological examination, so X-ray, that can only be provided within certain locations, but a lot of treatment can be brought to patients rather than patients having to travel to that treatment.
Okay, thank you. Councillor Matthews, would you like to come back at all?
Yes, only to say I'm not surprised by the defensive position that our two colleagues have taken, because of course they are trying to close it down because it suits them to have a different type of service. Whereas we're quite quiet here on the coast now because we were in lockdown. But we need Louth and Skegness as 24-hour urgent treatment centres, and then we need to stop the vetting through 111 and actually encourage people to go to the hospital to get treated for urgent cases. The situation will be turned on its head then. I am afraid I am still not convinced that this is not a closure by stealth approach, with all of the justification that we've just heard saying, better for us to come to you, but unfortunately we can't take an X-ray and we haven't got a doctor and we can't fiddle with your knee and we can't do all that. It's not happening here. And me, and as a personal patient, yes, they were charming, but quite frankly, I was the only patient in the whole hospital. That's not right. That means something is going on about the way that hospital is being promoted as being open for service. And I don't want any answers because it will be the same. We're doing our best for you. In fact, the situation is dire. Louth Hospital and Skegness Hospital are clearly an embarrassment because they're expensive to maintain. They need staff, so it'd be better to close them and have community service that can't be tracked as being effective. So I don't want an answer. I'm really unhappy about this. Thank you very much.
Okay, thank you, Councillor Matthews. Before I bring you both in, Maz and Tracy, I just want to build on what Councillor Matthews has had to say. I mean, I'd like to ask the question, in this instance, does the temporary closure of Skegness and Louth urgent treatment centres overnight, in this instance, actually mean temporary, or is it simply a repeat of what happened in Grantham?
So I'm happy to come here. This is a temporary measure due to our response to COVID. I absolutely, like you, want both hospitals to be a vibrant hub. It is the business that we are in, and we are not looking to close these hospitals down by stealth as a provider of these care. Quite the reverse. We see them as absolutely being a step down from acute and a step up before stopping people to going into an acute service. We absolutely agree with yourselves that, care closer to home, particularly around community. So I do have to disagree with the comments that there is some way of that we are looking to close these hospitals. That is absolutely not the case. Quite the reverse. I do make no apology, though, of wanting to protect my people, my workforce during a global pandemic, and also my patients. And I speak very strongly about that we have really stringent infection prevention control. So Tracy's absolutely alluded to cleaning, but also that reducing of transmission is about ensuring that at this present time, whilst we do not have a vaccine and COVID is very prevalent in the community, we have to do all we can to stop transmission for not only our population, but for our loved ones. Thank you.
Thank you, Maz. Tracy.
And we are absolutely committed to delivering the community hospital and that care closer to home. We have recently, as part of our workforce kind of strategy, gone out to appoint 12 RN apprenticeships, and we've prioritised community hospitals, particularly across the East Coast and Skegness, to have those RN apprenticeships, and that's an investment of taking, you know, people through 3 years of training so that we've got a workforce for the future. And I think it's, you know, I really strongly believe that we have a solution to some of the workforce challenges that we have across the East Coast, and we really are looking to maintain those services and build them for the future. This isn't about reduction at all. We absolutely want this service to be the vibrant community hub. We want it to be embedded within the local community and with a local workforce, which is why we've invested in RN apprenticeships to deliver that.
Thank you, Tracy. I must say I visited Skegness Hospital myself a few weeks ago on a Saturday. It was incredibly busy, but your staff are a credit to you. They were absolutely superb. You know, I would, you know, commend them very, very highly. Councillor Brewis.
Sorry, Chairman, I'd asked mine and I'd dropped my hand.
That's okay. Thank you, Councillor Brewis. Okay, in which case I've just one further question, if I may. And that is, clearly we are now in a second wave of the COVID-19 outbreak and back into a full national lockdown. However, with East Lindsey's decision to extend the caravan park season likely to have an impact should we come back out of COVID restrictions again, then surely there's going to be a higher need for the urgent care overnight in this area. And is that something that you're considering?
Yeah, and as I talked about earlier, we are monitoring all our activity to ensure that we are able to respond. And whilst we went out to public kind of engagement to look at the public's views around our continuing temporary overnight closure, it is under constant review. So if there was an increase in activity and there was a requirement to reopen these services overnight, then we would do that. We're not not looking to focus on that. And I think earlier when we were talking about postcodes, obviously PE25, which is the Skegness postcode, in July, November 19, 4% of patients are going down to Pilgrim. So that question about are they now attending the A&E at Pilgrim, 4% of patients were from PE25, and in July 19, 4% of patients are from PE25. So when I'm talking about postcode analysis, that's the level that we're looking at to see whether there are any triggers that we need to take account of, which means that we need to change how these services operate overnight. And I know I keep reiterating this point, whilst the UTC is close to walk-ins overnight, we are still able to respond to patients in that locality, either through home visiting, and we have home visiting hubs across the county, or by being able to do that advice and guidance and treatment via the clinical assessment service. So there is still a service available to that local population. Thank you.
Okay, thank you. In which case I'm going to move to a proposal, please. I'd like to propose to record the committee's support and thanks to all staff providing urgent care in Lincolnshire, to support and commend the Trust on the opening of the Gainsborough Urgent Treatment Centre on a walk-in basis from 8 AM to 8 PM from the 2nd of November, and to confirm the committee's view that the changes to the opening times at Louth and Skegness Urgent Treatment Centres should only be a temporary measure during the COVID-19 pandemic, and there should be an aim to reopen these two centres in the longer term on a 24/7 walk-in basis, as set out in the Healthy Conversation Engagement exercise of 2019. Do I have a seconder for my proposal?
I'll second that, if I may, Carl, and as long as we're going to deal with the other matter I raised in the programme at the end.
Certainly, we'll take that through to the work programme, because I think, as has been alluded to by both Maz and Tracy, it isn't necessarily for them to be dealing with, and I think that is something we can raise with the Clinical Commissioning Group. Councillor Matthews, it's been proposed and seconded. Do you want to come in on this?
Yes, and I know we're going to vote, but we've heard constant reference through this defence of the community hub places. Could we have a list of where they are, please? Just interested to know, because no one in my community is aware that there is one here to support them. So I'd just like to know where they are. But that doesn't need to happen this minute. At some stage after this meeting, if we could be provided with that information. Thanks, Councillor Macy.
Certainly, we'll take that on board, and I'm sure that information can be sent through to Simon and he'll disseminate it out between all members. Thank you. Okay, if you could please switch on your cameras. You've all heard the proposal. All those in favour, please show with a sign of hands.
Can officers please take the cameras off? Right.
Councillor Woodliff, could you either show in favour or not?
I want to abstain.
That's fine for the moment, thank you. Just checking.
So 4, I've got 3, 6, 9 on the screen, Chairman, at the moment.
Thank you. Okay, in which case, those against, please. Can you show? And abstentions, please. Can you show? Thank you, Trina. What's the outcome, please?
Well, I've only got 9-4. Did some of them not put the cameras on to vote?
It's difficult. Mine's only coming up with 9 at the moment myself.
Yeah,
so.
mine is 1, 2, 3, 4, 5, 6, 7. Do you want to just do a roll call, Chairman?
I think it might be better in this instance if you can't see the cameras. I think it's.
I can't. No, I can't see it at the moment. Right. Can we just have a roll call, please? Then, if I go through, Councillor Bill Bilton.
4.
Councillor Chris Brewis.
4.
Councillor Matthew Fido.
4.
Yeah. Councillor Lucille Hayes. 4. Councillor Sandra Harrison.
4.
Councillor Cabry Brown.
4.
Councillor Rob Kendrick.
4.
Councillor Carl Macy.
4.
Councillor Colin Matthews.
4.
Councillor Robin Renshaw.
4.
Yeah, in that basket.
Councillor Glynis Scalese.
4.
Councillor Angela White.
4.
Councillor Mark Whittington.
4.
Councillor Stephen Woodliff.
Abstain.
Councillor Ray Wotton.
4.
Okay then, Chairman, so that's 14 for, 1 against. Abstain, sorry.
No, we'll abstain. Please get
Abstain.
it right. Thank you.
Okay,
Thank you,
I'd like
Chairman.
to thank our presenters as well for coming this morning and walking us through the papers. And I'd now like to move on to agenda item 6, the primary care services. You'll find this on page 37 to 78 of the agenda pack. It is a correction, page 77 of the agenda pack, the 4th paragraph. The reception roll runs from 8 a.m. to 4 p.m, not 1 p.m. as stated in the original version. I'd now like to welcome our presenters. Sarah Jane Mills, Chief Operating Officer for the West Locality for the Lincolnshire Clinical Commissioning Group. Dr. Aubrey, Clinical Director for Lincoln City South Primary Care Network. And Dr. Akram, Clinical Director for Market Deeping and Spalding Primary Care Network. I'd like to hand over to you for the presentation. If you could keep it to about 15 minutes and we'll take questions at the end, please. Thank you.
Thank you, Councillor Macy. I'm just checking that both Dr. Akram and Dr. Aubrey have joined us.
Yes, I'm here.
Brilliant.
Thank you, Sarah.
Excellent. So just by way of an introduction, Dr. Aubrey is a GP in, I was hoping to be able to share a video, but I don't think I'm going to be able to do that today because my system doesn't allow me. I think it's because I'm a visitor, so we will share that in a future date. So in the report, what I've covered today is 3 main areas. The first has been the response during the first 3 phases of the COVID-19. The second is the current arrangements that we have in place for local people so that they can continue to access primary care services. And the third is the development of primary care services as part of the wider integrated care agenda for people living across Lincolnshire. So by way of introduction, there are 85 GP practices in Lincolnshire. 84 of those are members of one of the 14 Lincolnshire primary care networks. The 85th is part of the PCN in Leicestershire and Rutland. And at your last meeting, you heard that they will be making an application to be realigned to the Leicestershire and Rutland CCG in the coming year.
The NHS long-term plan recognised that if we are to deliver effective health care fit for the 21st century, the role of primary care is central to achieving that. And specifically, the introduction of primary care networks signalled a real and very tangible commitment by the NHS to change the nature of the relationship between primary care and the wider health and care community. In terms of, it is no longer just individual practices serving local communities, but it is now complemented by practices coming together and working as an alliance, as a PCN, a primary care network. In Lincolnshire, we are very fortunate in that our 14 primary care networks have actually come together to form an alliance, and we will talk more about that later. But I have attached a copy of their first annual report, which I think just shows some of the excellent progress that they are making and some of their ambitions and plans for the coming year. At the beginning of this year, obviously, as a wider healthcare system, we were declared as a level 4 national incident, and for primary care that signalled a very, very significant change in terms of how they were asked to operate. It expedited plans to introduce the use of remote consultations so that we could reduce the footfall of patients attending practices, whilst practices did continue to offer face-to-face appointments for people where that was clinically indicated. The majority of first-line interventions were either through telephone or technology. PPE and infection control measures were intensified so that practices were able to manage the risk both for their staff and for people attending the practice as they needed to. And we stood up a number of hot sites. Basically, this is a site where patients who were suspected or were confirmed as having COVID-19 were able to attend should they require face-to-face appointments. All of the primary care providers refreshed their business continuity plans, and what we experienced was that this was a really positive coming together of our primary care networks, and in the majority of instances practices worked together so they best used their collective facilities to actually support the response, with a number of places setting up hot sites as hubs rather than individual practices. In rural communities, adjustments were made to ensure local access was available. During phase 1, as with colleagues in the acute trust, a lot of the routine health checks were paused, and patients were advised that they would be rescheduled. And finally, we worked with colleagues across the wider health and care community to ensure that the response for those patients that were identified as vulnerable was available. That included not just people living in their own homes, but specifically working with social care colleagues and the care home sector to ensure that people living in care and residential homes were able to access excellent primary care support. And in Lincolnshire, we were very fortunate to be able to roll out technology that enabled care homes to provide vital information to their primary care teams and community colleagues, again to ensure that residents could access the treatment whilst we minimise the number of people visiting their own homes. The second phase, we maintained the arrangements to reduce the number of patients required to attend practices, and those arrangements still stayed in place. We did review the use of hot sites and step those down, although they are still available should we need to re-establish them. And we did begin routine health checks and other activities that had been paused during phase 1. One of the major concerns, which I think you touched on earlier when talking from colleagues from the Community Trust, was the fact that a number of patients weren't actually attending practices for symptoms that might suggest a serious illness. And so we did a lot of work to try and encourage people to actually make contact with their GP, particularly if they had symptoms that might represent a cancer diagnosis. And we did see a significant improvement in people attending and a return in the majority of our tumour sites to normal referral patterns. And then in phase 3, the guidance encouraged practices to return to normal service provision and particularly accelerate the arrangements for the backlog of patients who hadn't had their routine health checks. What I'll do, Councillor Macy, is I'll just continue on the access arrangements and then I'll pause because I noticed Councillor Burris has got his hand up. In terms of practice arrangements, there are 3 different arrangements in place, and each practice as an individual business unit selects the one that best meets their ways of working. So these are telephone consultations where the patient rings, books an appointment, and the clinicians call the patient back, does the consultation, the initial consultation over the phone, and then determines what next. And that might include prescribing treatment or face-to-face consultation. E-consultation is very similar in terms of patients, again, ring the practice and make an appointment, but they can also access their GP for other advice through the website, and that includes getting advice from their GP, self-help information or administration support. Again, if the outcome is that the individual needs ongoing contact, that can either be face-to-face or telephone or email or text. And in many instances, that's indicated by the patient. The final is Ask My GP, which is a total web-based service. What that means is that for the majority of patients, they register and record what their concerns are through the web-based service, and that enables the GP or clinicians to review that and then respond. If patients don't have access to that web-based service, they can contact the practice by phone, and the receptionist will record their information for them. So there is no disadvantage to those patients who prefer not to use the internet or don't have access to it. All the demand for practices using Ask My GP is managed through that same system, but again, the outcomes will be determined by clinical need. I'm going to pause there, Councillor Macy, in terms of whether Councillor Burris wants to ask a question at that point.
Yeah, I've got a number of listed people to ask the question. Councillor Burris is about third at the moment. So I ask Councillor Whittington first, if I may, please.
Yes, thank you very much, Mr. Chairman. Thanks, Sarah Jane, for the presentation so far. I want to ask a question on from 2.1 on page 38 of the report, which refers to the to currently the 85 GP practices in Lincolnshire, and 84 of which will be part of the 114 primary care networks, and refer to the 85th. I'm presuming that is the Woolsthorpe by Beaver surgery, which is in my division. I'm a bit concerned actually, because it's my understanding that the final decision on what was happening to the Walsall by Beaver surgery would actually be considered at the primary care commissioning meeting, which is actually currently on at the moment, because I've got it on my other computer here, so I'm currently listening to Jerry and John speaking. But the Walsall by Beaver isn't on that agenda. And I'm just wondering why it's not on the agenda, because certainly the implication from 2.1 is that the decision has already been taken.
No.
Walsall by Beaver, well, that's...
So if I can just clarify, practices can determine which primary care network they want to be part of. That is not a statutory responsibility. That is about the practices that they work with. And individual practices can determine which primary care network they want to determine. The decision, I was very clear in 2.1 that they will be making an application to be realigned in the coming year. And that's, as we discussed last time, that application has not been approved, and it would be for the decision of the receiving CCG, as my colleague Claire Raybould explained last time. But in terms of a primary care network, the practices determine which network they would like to be a part of, and that's why there is a difference.
Thanks, Eric. If possible, could I just ask a very quick follow-up, Mr. Chairman?
Yep, certainly.
Thank you very much. Obviously, we were led to believe that this was going to be, the decision was going to be discussed at a public meeting on the 11th of November, which is today. And I can see on the agenda that obviously the Lakeside in Stamford is being discussed, is the main agenda item today. I mean, I'm a little disappointed that we were told Woolsthorpe was going to be on this agenda and isn't.
So
is Woolsthorpe going on to a future agenda? Because I know that in comparison to Lakeside, it's a very, very small practice. But the issues and concerns that have been expressed to me by my local residents are very similar to those being expressed by the residents of Stamford. And I'm entirely supportive of the residents of Stamford. But actually don't want the residents of my division, Walsall by Beaver. There's only 1,600 of them affected by this, but it's still a considerable number of people, a lot of them whom are elderly and vulnerable in a very, very rural area with very, very little public transport, who are potentially now going to have to make a journey of 4 or 5 miles where there is no direct bus service, and they're going to be dependent entirely upon either access to a car or persuading family or friends to take them. Thanks, Mr. Chairman.
So thank you, Councillor Whittington. Yes, the current process, the current issue is not with regards to the realignment. The current issue was an application to close their branch surgery, and they are currently, I'm not sure whether the consultation is quite finished or whether they are concluding the consultation. I just can't remember the actual dates. Once that consultation has been concluded, then the Primary Care Commissioning Committee will take the feedback from that consultation, which will include the comments made by yourselves at the last meeting, and then they will determine whether that application would be approved or otherwise. So yes, it will be. I just can't remember when the consultation actually concluded or concludes, and as soon as that's concluded and the report is finalised, then that will be considered by the Primary Care Commissioning Committee.
Thank you, and that will be a meeting in public.
Yes, it will.
Thank you much indeed. Thank you, Mr. Chairman.
Thank you, Councillor Whittington. Obviously, this is something that we've written in with our objection to at our last meeting, and it will be something we keep a close watching eye on anyway, Councillor Whittington. Okay, Councillor Mrs. White, I have you next.
Thank you, Chairman. My question relates to Appendix 3 on page 77, which is Ask My GP case study. I query the validity of this case study owing to lack of context and numbers. The practice is 9,500. On what evidence do you base the conclusion that over 60% of patients now prefer online consultation? Do you mean 60% of patients who gave feedback? If so, how many gave feedback? Between 60% and 70% of all practice demand is now online. I can see that you can monitor that, but it'd be useful to have a timeline and numbers. Feedback shows that 95% of people prefer the new system. On what evidence do you base this? Do you mean 95% of patients who gave feedback? If so, how many patients gave feedback? My point is, I don't expect you to have these numbers at hand, but I would say to have any validity, this case study needs additional clarification.
Thank you, Councillor White. And yes, we can provide that additional clarification. I think it was by way of indicating that this was something that was quite different, and that patients that have been using it have found it quite a positive experience. But yes, absolutely, if you would like additional data, we can look at providing that going forward.
Because it's so positive, but it's not based on numbers. And I think I'm getting a similar message from Nettle Medical Practice. We're not getting the negative response, of which there is some.
So, Dr. Aubrey, I don't know if you want to make any specific comments about feedback from patients.
Thank you, Sarah Jane. So the case study is based on my practice. The numbers that the 60% online, and I believe it's higher than that now, is for all of our contacts, the ones that don't come in directly online, that come in through the telephone system from the receptionist, and the system differentiates between those, and we get reports on the system automatically does reports, and it will tell us what percentage are coming in online and what percentage are coming in through the telephone. But I take your point about numbers. In terms of the negative feedback, the people who, I believe about 10% of people who use the system will give feedback. So I take your point about there are some people who are the people that are coming in through telephone that won't be using the system themselves, and if they have negative feedback, they wouldn't necessarily give it. I think Sarah Jane's right. I think probably we need to put that in context with some more data and some more information behind it, rather than something that I can explain right now.
Thank you.
Thank you. Just before I bring in Councillor Lewis, I think it's probably more wide-ranging even than what Councillor White would raise. So one of my questions is, what level of complaints are both the CCG and PCNs receiving on the lack of access to GP appointments, telephone access problems and internet? And can the numbers and trends of these complaints be shared with the committee?
Yes, we are receiving feedback regarding some challenges in terms of accessing some practices. It is not by any stretch across all of the 85 practices across the county. I'd be very happy to share that with you, Councillor Macy. What we are doing, and I'm talking to colleagues from Health Watch when I manage to catch up with them hopefully next week, is with regards to actually identifying and investigating more generally. So what are the challenges for people? As I've highlighted in this report, the pace of change to the new arrangements was expedited because of COVID-19. That is not an excuse, but it is a reality of the fact that that didn't allow us, in some instances, some of the time to make the changes that you would want to make. And we are aware that there are some practices where there are particular problems getting through, in the main on the telephone. We're working with those individual practices to understand whether that is a demand issue, and whether using other vehicles such as e-consult might help with some of that demand, whether it's an infrastructure issue, as in whether the phone systems have actually got the capacity to deal with the volume of demand coming through, or whether it is a staffing issue. Without doing that further deep dive of investigation, we will we won't be able to determine what the issues are for individual practices, and I think it would be wrong to say it is any one of those things, because it will vary on the individual practice basis. But very happy to share with you that we are also aware that in a number of instances, those practices that are struggling in terms of providing effective access did have some challenges prior to COVID, and we were already working with them to look at those issues and looking at how we can address those. So very happy to share that with you, Councillor Macy.
Sarah Jane, I have a list of 5 other speakers, and then I will close down the debate because I'm conscious of the time.
Okay.
Councillor Brewis, you're next.
Yeah, thank you very much. Councillor White touched on what I was going to do. Then I look on this very much as a brief snapshot in the middle of COVID, and what happens during the COVID period would be a very bad time to make any real serious decisions. And part of the fact is that the people least likely and least able to do online consultations are the those who are less privileged and more elderly, the very ones who nationally we're being told a lot of diagnoses are being missed, and there will be sad deaths as a result in the future. So I think we've got to be very careful before we start to judge things during this current crisis. But my other point was on page 55, I discovered the real number 85. First of all, I want to point out that number 59, Deeping, is nowhere near where it's being put. And Sutton Bridge has been completely missed off, which I think is number 85 on the map. And I'd just like to make sure, may I also pay a compliment? I am currently at the moment, and recently as yesterday, have undergone my treatment for what's called post-cataract clouding. It was very, very good, and I can see better this morning than I could yesterday, and I've told after 4 days it'll be even better. So I want to say, certainly at my end, that the Sutton's practice and the pharmacy are absolutely fabulous, and I'm very grateful for them, despite my criticism. Thank you.
Yeah, thank you, Councillor Brewis. And I think the point you make in terms of we are currently in the middle of a national emergency and a crisis that will influence the way of working, and that shouldn't, it should inform but not influence our future planning, which is why I was very keen to make sure that as in presenting this report, I highlighted the fact that the future plans need to be very carefully worked through and supported by our local communities. In terms of the vulnerable people that you are highlighting, one of the main issues that practices focused on actually during all 3 phases and continue to focus on are those patients who are at risk of becoming extremely unwell because of COVID-19, or actually unwell because of existing conditions. All the practices have reviewed their patients. Their systems enable them to do that. They've highlighted those patients who are at risk. And they are proactively working with colleagues. In some instances, those patients may well have been, from a health perspective, very stable, but actually from a social perspective, quite isolated, particularly during phase 1, when people were encouraged to shield. And this is where the strength of working with colleagues, both in the social care sector and the third sector, really demonstrated how coming together the community can support those very vulnerable patients. And there was some excellent work done by colleagues in social care and specifically the wellbeing, which I know is a very effective service at reaching out to those patients whose health may have been stable, but actually who would have become quickly poorly if they hadn't have been receiving that support. And I think one of the things going forward is not to make decisions based on the reality of what is a crisis, but actually look at both the strengths and weaknesses of the current situation. And without a doubt, the strengths of the different parts of our community coming together is something that we need to absolutely retain and build on, because that is how we support our most vulnerable. So I couldn't agree with you more. And I'm pleased to hear you having good experience.
Sarah Jane. Briefly, thank you, but just to say too, I think that this crisis may be with us for quite a while, and the most encouraging thing I hear you say is the way all the agencies are working together. And let's hope that carries on after this crisis as well.
Absolutely.
Thanks very much.
Sarah Jane. Councillor Macy, if you wouldn't mind, wouldn't mind if I say a couple of words.
Yes, sorry, I did.
Yeah. So I think what's very evident is that clearly, there is a desire for there to be, more kind of scrutiny, of these new methods of kind of access to primary care in particular. And I just wanted to kind of just emphasise the point, which I'm sorry if it's already clear to individuals, is that actually, access has always been one of the major issues. It's one of the biggest kind of, patient complaints, and feedback to general practice in particular, as I say. What online does is that it's just giving us another avenue for patients to be able to access. So my practice in particular in Deeping, we use eConsult. So, I know we've talked about the Ask My GP case study. Actually, by using eConsult in my practice, we are offering patients access to the practice from 8 a.m. Monday morning all the way through till 6:30 on Friday. So actually, even when the doors close at 6:30 Monday, Tuesday, Wednesday, Thursday, patients can still access the practice via that online method. So actually in the morning, they don't have to wake up early and sit in a queue in a phone line. And actually there is a commitment to answer those online, consultations within 24 hours. So actually, there is kind of a check and balance, and we are reviewing data continually. And one of the things, I'm involved, we've set up a primary care digital delivery group in the commissioning group, so that actually there is governance and scrutiny, of digital infrastructure that's actually being implemented and deployed. So please rest assured that actually, your comments will be fed through to that group to say, well, actually, we need to continually kind of, assess these methods. And the final thing I wanted to say is that one of the other things that has happened alongside all of what COVID has brought us is that actually our primary care networks have gone from strength to strength. And what some of you might have found when you've contacted your practices recently is that now we have practice-based senior physiotherapists, we have pharmacists, we have occupational therapists. And actually, the beauty of online sometimes is that actually, because the practice has time to digest the information that's coming through, and actually more information is available rather than just a sentence of why the patient wants to come in. Actually, we can navigate that patient to the right professional. And the GP, I'm a GP myself, and I've learned over this last 6 months to say this, is that actually the GP sometimes isn't always the right person to see. And actually, if you have a musculoskeletal problem, seeing a senior, very experienced physiotherapist. So, and I labour the point of senior because these are only the people that are being employed by these PCNs, and senior pharmacists might be the right person to review your medication with. So actually online is allowing us to do that. And actually, I'm sensing that there may be some fear that actually, are we going to go down an online only method? And actually, just to reassure, online happens to be, on the menu of that suite of access to general practice. And actually, telephone's not going to go away. So every patient that uses online because they prefer it actually frees up the phone lines for someone else who doesn't like online. So telephone's going to stay there. So I just wanted to add that, Sarah Jane.
Thank you, Dr. Akram.
Thank you, Dr. Akram. I think that was very useful. Unfortunately, it's not the case across all of our areas, but there we are. Okay, Councillor Harrison.
Thank you, Chairman. Good morning, Sarah Jane.
Morning.
I pretended I was a member of the public after reading your papers, and I had a real job. I went on Google to find details of my own practice. There were about 5 entries, but none of them were up to date, and there was nothing on those about the new methods of contacting your GP. And following that, I made a phone call to the surgery, And yes, I had the usual recorded message, but there was nothing on that at all about options for contacting the practice if you were unable to get through on the telephone. So I am a little bit concerned about whether all the practices at the moment are fully engaged with the new methods. I won't mention my practice name, it's not relevant, but it's just something I would like to raise.
Thank you, Councillor Harrison. Yes, not all the practices are currently using either eConsult or Ask My GP, which is why I've made reference to the fact that there are 3. Some practices still are using just the telephone methodology. I think across Lincolnshire now there are 9 practices that aren't using either eConsult or Ask My GP. And we are working with those practices to understand why, as Dr. Akram has said, and I'm sure Dr. Aubrey will agree, those practices that have moved to that, it does open up different ways of accessing. And I think from a general public perspective, that can add value. It doesn't distract from those patients who prefer a more traditional. But yes, I think going forward, we would want to have all those routes of access available through all of those practices. It is one of the peculiarities of general practice in that they are individual business units and therefore they will determine which is the best method for them. And what we can do is encourage them. And I think in some instances, for some practices, at this point in time, maybe that decision is right in terms of they were struggling. We know that some practices have struggled with the change in implementing it very rapidly. And one of the things that has been established on the back of COVID is quite an extensive primary care support team that now can work with those practices to look at what their concerns are and how we can help them. But ultimately, from a CCG perspective, my ambition would be that everybody would have that suite of access.
Thank you. Thank you, Chairman.
Thank you, Councillor Harrison. Just building on from what Councillor Harrison has asked, it does state on page 73 to 75 of the report that a number of the PCNs have e-consultations planned. Do you have timescales for this? And if so, can you share them with the committee? Because I'm sure that members across this committee will tell you it's very differing from area to area, and I know in my own personal area it's incredibly difficult to get through to a doctor. It's more likely you'll end up at urgent care because it's the simpler route, and if you do get on the phone, you could be on there for 45 minutes without speaking to anyone, and many people just give up.
Yes, we can give you the timescales for the implementation of those that are planned. And I couldn't agree with you more, Councillor Macy. There are some practices, as I highlighted earlier, where we are aware that it is extremely difficult for patients to get through, and that does result in them using either the urgent care centre or going through 111, both of which is absolutely fine if it's a minor illness and the patient requires treatment on the day. Clearly, if it is something more significant, we want to try and make it possible for those patients to access their GP practice because they are the practice best based to work with that. And that is why we are committed to looking at the specific information from those individual practices and then looking with them to determine how we can best support them address those issues.
Thank you, Sarah Jane. Okay, I have Councillor Renshaw next.
Thank you, Chairman. Well, I carry on with the same thing. The problem is patients feel exasperated if they feel they've been abandoned. And that has a repercussive effect because it causes them anguish and mental health problems. And that's not another. We don't want patients in mental health if it's unnecessary. My experience with the Ask My GP is that long-winded adverts need to be subject to précis before inclusion in the text. As our parents would have told us, more can be said with less, and I'm sure that would be welcomed by all. And the length of the call, varying a lot of what people have said to me is drivel, but it's obviously an urgent message. But the GP's lines are not there to be a communication channel for HM government, because if we could send a message out about COVID, that is another channel. Many patients do not have landline, and that's the other issue. So a long protected message will make callers ring off, as the chairman said, or they'll be cut off due to limited credit. I accept it's not a quick fix, but reductions in message time make more capacity for the practices to manage more patients. They can get more in, more. What's the thing for the phrase? More callers for the money they're expending. So it makes it's a yes and a positive message for everybody. Thank you, Chairman.
Thank you, Councillor Renshaw. Unfortunately, the messages that practices are asked to include on their landlines are actually part of our national request at this point in time, and we do need to make sure that people are aware. I don't disagree in terms of sometimes they can be extremely lengthy, and we are working to try and look at how we can support practices by, rather than each practice actually developing their individual message, which obviously they still could do, we look at how we produce messages from a sort of like CCG perspective that actually might address some of the concerns. But unfortunately, we do have to provide those messages so everybody is aware.
Thank you, Sarah Jane. Okay. Councillor Kendrick.
My questions are on the future planning as indicated in the report, and it's a two-part question. The first one is basically on concerns that have been raised with me by residents in my division relating to sort of population change and the effect on the provision of primary care, usually around the new developments. I mean, in my own division, we've got a major housing development on the cards. And residents have asked me what planning is done to accommodate that in the future. And the second part is the funding of new roles. I mean, it's to be welcome to see more skill sets in primary care. I think that's brilliant, and particularly on things like mental health, which is such a major issue these days. But I was just wondering how that might be funded. And also, I noticed that physiotherapy is OT is included, but physiotherapy is not included in that. Bearing in mind that musculoskeletal problems are one of the major things that people consult on these days in primary care, is there a particular reason that physio is not included in that one?
So I'm going to invite my two colleagues to come in terms of the new roles. I'll answer the question about the planning. Yes, in terms of if there are significantly large housing developments, then the CCG is contacted, and clearly we work with practices to look at the implementation and the implications, often which are many years ahead, and it links quite nicely to some of the primary care network and the conversations you were having at the idea of clinical hubs, so that we start to use assets in our communities in a more creative way. I'll go to Dr. Akram first in terms of the additional roles, and then Dr. Aubrey in terms of further developing that.
Thank you. So, as I think, as I mentioned earlier, we're going from strength to strength in terms of our. Bear with me just 1 second. in 2017. Actually, I'm having a problem with my computer, Sadie. Do you want to go? Do you want to continue, and then I'll come in after?
Okay, Sadie.
Right, so in terms of the additional roles that you're hearing about in general practice, that's part of the additional roles reimbursement scheme, which is specifically for PCNs. It's determined by NHS England, not locally and not regionally, as to what those roles are. So your comment about, why is it this, why is it physios, not OT, or so the other way around? That is dictated to us centrally. So we and within the roles as well, it's not, so for example, an OT, it has to be a particular level of OT. Physios are actually included, but there was something called first contact practitioners. So rather than the kind of physio that you'd go and see if you had a knee injury or something, it's who actually does the physical work with you. It's a physio who can assess, diagnose, and often they can prescribe and inject as well. So it's that level of physio. So physio is included, but it's not the kind of physio that you think of as physio. It's much more advanced physio. So the answer to your question is the roles that we can recruit are very much prescribed to us and specific. But each PCN has an envelope it has a budget, and the PCN can choose which of those roles and how many of those roles that they recruit to. And that's based on their local population need. PCNs are all about population healthcare. We look at, what's needed on the East Coast is going to be different to what's needed in central Lincoln. So, for example, in my PCN, we have a higher level of elderly and frailty, and we're recruiting occupational therapists. We've recruited a health and wellbeing coach, a care coordinator. But in another place, for example, central Lincoln, they might be going more heavily on the mental health practitioners, which are available to us from April next year. So working within what's dictated centrally, we're trying to make sure that we provide what's needed for our population, and that those people work, those additional roles, they work in really close correlation with what's already there in primary care and also with each other. We're not looking to just put an OT into a practice and say, off you go. It's very much about wrapping it around patients, saying, what do our residents actually need, and providing that, as opposed to saying, there's a service, let's see who can access it.
So if I can just add to Sadie's comments, actually, Sadie, it's good that you went first, because from a PCN viewpoint, I think that you're absolutely right. Some of it is market forces as well, in that when I say that, I mean, you can only employ the pharmacists that are out there. And Lincolnshire, generally, as healthcare providers, we have huge challenges in terms of attracting staff here. And actually, for some reason, the last 6 months have been slightly easier in terms of recruitment. And actually, all of the PCNs have worked tirelessly to actually fill all their positions. So actually, we're in a position of strength in terms of having pharmacists and now occupational therapists. And I've just shared a little clip really in terms of the work that Lincolnshire has done in terms of first contact practitioners who are senior physiotherapists to do basically from the point of a patient contacting reception. They're seen by this individual who can see, examine, test, diagnose, even refer on. I'm proud of it because I was involved in the pilot in the south of Lincolnshire. But actually, it's something for us all to be proud of, because now this is not only that it's rolled out throughout Lincolnshire, but the whole of England. NHS England, needed this work to be done, and it's been done. Physiotherapy, the hands-on physiotherapy that you need, clearly is a little bit of a challenge at the moment, given with COVID. But my understanding is that through the community services, I think physiotherapy is becoming more and more available as well.
Can I just come back to Sarah Jane? You mentioned the size of the development. I'm bound to be asked this question at some point. Is there a threshold? Because I sat on the planning committee on the district council for many years, and I have to say at some point there were criticisms of the NHS by members saying that they were rather laid back in their response to as a consultee. So is there a threshold over which that you must be consulted, and what happens if it's lower than that threshold?
No, there isn't a threshold. I think what has often become confused is the health service, general practice, is able to make application for Section 106 funds, which are capital funds. And for smaller developments, because of the criteria for how you could use
those funds. Actually, there was a lot of work involved and the practice gained very little benefits. So for a long time, the health service didn't look at very small developments because it was, £1,000, and actually from a capital perspective, there was very limited work that you could do. That is changing in terms of we are working much closely with all of the district planners to look at how we can enhance healthcare services in a more inclusive and comprehensive way, because again, the criteria was very much about the practice in the sort of like the catchment area. Well, working with primary care networks and looking to develop health hubs, and particularly where we have roles that will work across more than one practice. So, for example, the first contact practitioner, for example, may well support 6 or 7 practices, or a team may support 6 or 7 practices. And so there is logic in terms of us having a facility where that person can operate out of. So increasingly, my colleague Jackie Bunce is working with district planners to look at how we make best use of the resources through Section 106, but also how we have the visibility, because half a dozen very small developments soon adds up to an extra 100 people, which, depending on the type of development, can mean quite a significant increase in demand for primary care. So I hope that clarifies that. Dr. Akram?
Yeah, can I just say to, I don't know if you're muted, Councillor Kendrick, I think you might be trying to say something, sorry. Yeah, absolutely. So I can, I'm glad that the conversation has touched on Section 106, because, in those areas where developments are going on, it would be, it would be very welcome if the local councillors or the local planning teams can kind of also interact with the practices to help them to develop those bids that they can work up with CCGs. So that would be, because we're currently going through one of them, and it can be quite a mind-boggling process, for a practice, where we're used to providing health services, but making use of these opportunities, which are usually time limited, isn't easy. So if there's anything you can do in areas of concern to reach out to the practices, that would be really appreciated.
Thank you.
I think as that's out of the control of us as the county council, our district councillors will certainly pick up on that point, and I'm sure try and help pave the way.
Thank you.
Right, thank you, Councillor Kendrick. I have 2 speakers left, and I'm going to close down the debate. I have Dr. Wookey first, please.
Hello, can you hear me?
We can.
Yep. 2 quick questions relating to item 6 again. The first is you talked about things in your document, but it is to some extent overtaken by events, because we're now in a lockdown, and some of the things that you were saying were being done are obviously might change. And in relation to that, can you give an assurance that PPE equipment and supplies are adequate at this time? Because we know that in the earlier lockdown, there was a lot of anxiety, both from patients and, in fairness, to health professionals as well, about communicating face-to-face because of PPE equipment failures. Not only supply, but the actual equipment wasn't adequate. And similarly with care homes, you've mentioned about care homes. Now we're in a lockdown where care homes are in a different situation again. Is there any modification in what you've said already about the relationship with care homes and the support to care homes and the links between care homes and primary care? And later on, but you may come to this if you're continuing to talk about support, that the CCG has said it welcomes feedback from the Health Scrutiny Committee, which is obviously what I hope you're getting now. But does that welcoming also apply to Health Watch? Because I know you have been working intermittently with us, but we get a lot of feedback from the public and can provide you with perhaps some information which isn't actually all that easily available. So those are just the queries, please.
I'll start with your last question. Absolutely, and I, in terms of working with Healthwatch, very much welcome the feedback that we get from you and your colleagues, both directly and through our various committees, and would go further to that in that as I've said earlier, I've got discussions scheduled with Sarah Fletcher to look at how Healthwatch as an independent body can actually support us further to reach out, engage people, because we know that they have done some excellent work in getting some feedback. They did a piece of work recently in palliative and end-of-life care, which was really invaluable. And so I'm going to have a similar conversation with Sarah going forward. So any feedback is always welcome, because I think it helps us understand the full picture and understand the concerns and anxieties. In terms of PPE, yes, early on, and particularly during phase 1, there were significant concerns about the flow of PPE and particularly to general practice. And all of those issues were worked on. There is now a much stronger supply arrangement in place where colleagues from general practice can order directly, but we still have across Lincolnshire a supplementary arrangement, so that if any practice does find themselves struggling, they are able to get some supplementary help from the Lincolnshire community. And what we have found, again, going back to the primary care networks, is that our GP practices really have come together. And if a practice has found itself short of anything, whether it's been PPE or there's been other things where there's been supply chain problems, the practices have actually worked together to make sure that the individual practices can continue to provide the services. So it's very well coordinated. Practices can access it directly, they work together, and then we've got the primary care team who can access through the LRF wider support should it be required, whether that be PPE or other things. In terms of care homes, you're absolutely right. When I wrote this report, we weren't in lockdown, we are now in lockdown. All the way through since phase 1, we've worked very, very closely with colleagues in social care and the care home sector to make sure that we minimise the number of people that are attending practices, attending care homes. Often you would find, a community nurse going in, seeing a patient, and then a GP being called in later. So there's a much greater coordination of who is going in. I'm going to invite Dr. Aubrey in a minute to talk about some of the other work that the PCNs are doing in terms of care homes. But across Lincolnshire, the rollout of the telemedicine, which has been targeted at care homes with the most vulnerable, does enable those care homes to provide some very important information very rapidly through to the practice. Which means that the practice can either prescribe remotely or make sure that the right person is mobilised, and we will continue to do this. They are one of our most vulnerable groups. We often think about patients who are in the more mature years, but actually there are a lot of people living in residential homes that are actually of adult age, with learning disabilities or mental health problems. So again, we look at the type of support that those individuals require. And one of the things is about, again, working with colleagues in the Mental Health Trust to make sure that practices are supported by our colleagues. It's not perfect, but I have to say, in the last few months, there has been some really significant developments with each care home having really clear points of contact, who they can contact if they need to. Dr. Aubrey, I don't know if you want to just talk about the work that the PCNs have been doing in terms of care homes as well.
Yes, so it's something that I've been involved in, and alongside the CCG is the Enhanced Health in Care Homes framework, which is based on some vanguards across the country, and it describes what were the essential principles for excellent care for residents of care homes. Part of the ask of PCNs this year is to work on that and start to develop more collaborative working between primary care and community services, voluntary services and care homes. And that's something that the PCN Alliance, so that's the group of all the PCNs across, the clinical directors of all the PCNs across Lincolnshire, something we've been working together on. Although we absolutely recognise and celebrate that our individual areas have their own needs, there are some things that are common across the whole of Lincolnshire in terms of what we can do to make sure we're providing excellent coordinated care for our residents of care homes. We work alongside our community partners, for example, LCHS and LPFT, who work all the way across Lincolnshire. So it's essential that some of the things that we're doing are coordinating with them on a Lincolnshire footprint, so then we can work locally to make sure that we're providing the care that our individual care homes need. Where we've got to so far is that we've had some excellent discussions with colleagues at LCHS, and we've been able to develop a framework agreement that describes how primary care will work with LCHS to really make sure we're caring for the residents of our care homes in a coordinated way, but also wrapped around the resident. So as opposed to saying, well, the primary care will do this thing and LCHS will do this thing and LPFT would, really looking at actually we need to work together. We need to make sure we're working out what does the individual resident need, and are we all working together to make sure that happens in a coordinated way. Also going to be in the process of having discussions with the Mental Health Trust on that as well. And the aim is to have a sort of overarching framework where we all know how we're going to work together, really so that we can enhance the health of our care home residents. Was there anything else? You want me to go into any more detail?
Add that Sarah Jane's already touched on a piece of kit that's now being delivered to all of our care homes in Lincolnshire called WAZAN. So basically, it's based on something called the National Early Warning Scoring System. So, when patients are unwell, it's very important for, those that are kind of in direct contact with that patient, whether they're, healthcare support workers who are non-clinical, they're not nurses, or even kind of registered nurses. So for them to kind of score that patient and to understand the urgency of, whether to contact the GP or contact the hospital. And I think once again, this wasn't something that was mandated, but, it was already pre-planned, but through our PCNs and with working with local authority, I think it's something that we've rolled out much faster because of COVID. So I just thought I'd also add that. And that's something that's for care homes.
Okay, thank you.
Right, thank you very much.
Thank you, Dr. Wookey. Derek Ward, were you wanting to come in at this point?
Thanks, Councillor Macy. Yeah, it was just to add to the care home discussion, really, and the PPE bit. WAZAN is one of the things that I think the scrutiny have already been cited on the part of the social care digital roadmap. We work really closely with CCG, GP practices, our colleagues in the NHS, to make sure we're increasing use of technology and access for residents of care homes and wider, and also each care home now has access to NHS Net, so that we've got a secure way to pass clinical information between different agencies, which is also helping. In terms of the PPE, as well as the process that Sarah Jane outlined, and I can touch on this when I do my update, we've also got a Lincolnshire Resilience Forum stock of more than 2 million items now. So the national supply chain has improved massively. A lot of the production is now done in this country, whereas obviously with wave one, a lot of the PPE we need to get in from other countries, and that caused a challenge. Plus, we've got a very significant stock that's held locally and distributed if we need it through NRS, who've done a really good job as well. So lots of positives and lots of learning from the first wave is all I was going to say on that.
Okay, I have Councillor Whittington with a very quick question, and I do want to be moving to my proposal as we're already half an hour behind, and Derek Ward's only got till 1 o'clock. Okay, Councillor Whittington.
Yes, thank you, Mr. Chair, and thanks for allowing me to come back, because this is something that came up during the question from Councillor Kendrick regarding development and Section 106 monies and the NHS accessing them, because obviously I'm a local district councillor as well, and I sort of picked up some of the comments that Councillor Kendrick has, that sometimes the NHS don't seem to be as forthcoming around Section 106 monies. And the bit about developments, I think is quite important, because certainly within just within the parish boundaries of Barrowby, where I'm currently based, if all the housing developments are take place, there'll be 1,000 new houses, but they're not in one development. They're in about 6 or 7 different bits of developments with different developers. And I take Sarah Jane's point that quite often a number of smaller developments can soon mushroom into large numbers of developments. And certainly within Grantham as a whole, the plan for 7,000 new houses over the next 15 years, they're going to be scattered around Grantham. I mean, potentially Grantham is going to go from 45,000 to maybe 60,000. I'm just wondering, and again, so I'm reassured that the health service is kind of looking a little bit more around 106 monies and about the impact that such a big increase in population is going to have on the requirements for primary care. But I'm a member of there's currently a working group at the County Council looking into Section 106 monies, because at the moment the County Council is just a consultee like the health service are with the districts, and our 3 main areas obviously are highways, education and public health. But there's something in the planning white paper which is of some concern, because at the moment a lot of developers have been having pushback around 106 monies, saying that it particularly affects the financial viability of their scheme if they have to make a whole load of Section 106 contributions locally. And the bit in the white paper that's concerning is that in future, any contributions could be based on the land value of the development. The implication of this could be that for London and the South East, where land values are high.
Up, please. I did allow you back in for a very short question. It has gone a little bit longer than I expected.
Okay, sorry, but I think this is a key point, because in London and the South East, if contributions in the future are based on land values, London and the South East are liable to get the contributions they want to. Whereas in a rural area like Lincolnshire, where land values are less, potentially the whole basis, Section 106 monies for everybody, not just us, but health service as well, could potentially be lost. I just didn't know if you and your team, Sarah Jane, were aware of this. Thank you, Mr. Chairman.
Yes, we are aware, and as I say, my colleague Jackie Bunce is she's part of the One Public Estate. She's very well connected with all of the district planning and linked to all of the issues that you've referred to. And just as a bit of supplementary information, not only do we look at the numbers of houses that are being developed, but also the nature of the house, and that is particularly relevant because, as Dr. Aubrey described, each primary care network is looking at their population, and a large development of a particular type of house could quite significantly change the population profile in an area. So all of that information is information we take account of when we're getting feedback, so that we can ensure that the planning takes account of health needs as well as the numbers of people. So hopefully that addresses that.
Thank you, Sarah Jane, that's helpful. I just have one very quick question, and if you could try and answer it quickly, I do want to try and finish off the item. And that is, what is the current thinking in terms of a return of face-to-face appointments And what is the likely timescale for some form of return to normality of GP appointments? Clearly, we're in a second wave now, and I know that that is going to throw things out a little bit.
In terms of face-to-face appointments are still available, and I'm sure Dr. Aubrey and Dr. Akram will both confirm that they do see patients on a regular basis, and certainly patients are attending for health checks and all the rest of it. Obviously, during lockdown, we need to be very sensible about who we're inviting back. In terms of timescale of sort of like how we will be operating in terms of what I would call the intensive infection prevention measures, I don't know. I have to be honest. I think the most important part from a primary care perspective, and hopefully this links with your summing up, is that even before COVID-19, primary care had its challenges. It was a very, it hadn't really changed its model. We've seen some acceleration of some new ways of working, which are have their strengths and their weaknesses. And one of the things that we will be doing, and really very keen to keep the dialogue going with yourselves and other colleagues such as Health Watch, is looking at how we continue to develop the new roles, the different ways of working using the PCN Alliance, using digital technology where it enhances services, and actually start to get into a perhaps much more dynamic dialogue with our local communities to shape what primary care will look like in the future. My personal view is I don't think we will revert to anything. I think this is a journey of continual improvement, and there are some really great opportunities that will improve access, will improve services. We've heard of a couple today in terms of the work we're doing with care homes, some of the improved access from the digital. What we need to do is make sure that we engage properly so we're meeting the needs of the total population and that we shape services. So I don't think things will revert. I think what you might see is a reduction in terms of the intensity of some of the infection prevention and control measures as we become more confident with our ability to manage COVID. Timescale of that is unclear, but I think we're on a very exciting platform for really starting to look at how primary care develops as part of that integrated community offer. And linking back to what Councillor Brewis said, I think this, the learning through COVID about how we've worked together with not only our colleagues in the health sector in the community, but Dr. Akram would talk about work he's doing with colleagues in secondary care and the way they're working differently, but also the social care sector and the third sector. I think it's a really very, very positive time for us as communities to shape how primary care develops. I don't know, Sadie or Majid, whether you want to add anything.
No, well said, I completely agree.
I think I do totally agree with you. Just to quickly just say that actually I agree with you that the vast majority of my clinical colleagues, clearly, social distancing, people having to queue outside, practices before they come in for safety reasons and reasons that have been mandated. But actually, I'm hoping that general practice won't look like it did previously. After COVID's gone, it will be different, and I'm really sorry to say that if that wasn't the expectation. But actually, there's no point having 3 or 4 face-to-face consultations with the wrong people and not getting sorted. So for me as a clinician, and I'm sure Sadie would agree, it's all about outcomes, and it's all about making sure that the patient's needs are met. And whether if that happens to be without a face-to-face consultation, well, I think in terms of quality and safety of care, that's a better outcome than actually, having our main aim to kind of restore en masse face-to-face appointments. And as Sarah Jane has said, myself and the other three clinical leads, we've personally written to every single GP practice, 2 or 3 months ago, to say that actually face-to-face consultations had to be restored. And actually, I can assure you, I'm sure Sadie will nod, that we are seeing patients face-to-face.
Yeah, we are, and we never stopped, and we will continue to see people face-to-face when they need to be seen face-to-face. And that might either be because there's a clinical decision that we advise people we need to see them face-to-face, or there might be some people that just really can't get on with the telephone call or can't do the email. So it's a decision between the clinician and the patient about whether they're seeing face-to-face. We're not dictating to people. It's very much a joint decision. But as we said earlier, in dealing with people that want to have the phone calls, that want to do the online access and the online conversations, in that way it frees up time for us to spend more time with the people who have the more complex needs and probably do need to be seen face to face. So it's about allowing that flexibility and allowing that joint decision making between clinicians and patients to make sure they get what they need.
Thank you, that's very useful. And I think it's something that the committee will keep a very close watching eye on. In which case, I'd like to now move to a proposal. Unfortunately, gallery view or large gallery view is not working currently. So I will make a proposal and we will carry it. And if there's any dissent, then, please raise. If not, it will just be moved forward. And I'd like to propose that we request the timescales for the e-consultations to be rolled out, and we receive the level of complaints received and additional data on the clarification of case studies. Okay.
I'm happy to second that, Chairman, and just tell Sarah Jane that if she lets me have her email, I've got a few radical suggestions for her on how to deal with planning contributions.
Thank you. So is there any dissent on that? No dissent? Okay, thank you. In which case, I'll thank our presenters. And we'll move rapidly on to agenda item 7, as we're already running quite late. I'd now like to move to the COVID-19 update, which you can find on page 79 to 92 of the agenda pack. And I'd like to welcome Professor Derek Ward, Director of Public Health for Council. Got a quick run through and some questions at the end. Thank you.
Thank you, Councillor Macy. We've put together a paper just to outline the roles and responsibilities of the County Council in terms of the response to COVID-19. But what I wanted to do really is just give a little bit of an update on the figures, where we are overall as a county as we are moving forwards with the lockdown, and then really leave as much time as possible to allow for questions and discussion, because I know there's an awful lot of questions that may come forwards. Overall, Lincolnshire continues to see a lower than the England average rate. There is quite a lot of variation across the county at a district level and as you go lower, but that's basically given the fact that as your population numbers decrease, if you have a small outbreak or even a medium-sized outbreak somewhere, then figures will jump up or jump down. So we're looking at a 7-day rolling average that tends to give us a good idea. When we compare Lincolnshire to the rest of the East Midlands, we are one of the lowest counties in terms of our rates. Again, other counties are a lot higher, and other places have had higher restrictions in place. So I'm sure all members will be aware that, for example, Nottingham and Nottinghamshire have had tier 3 restrictions in place for a couple of weeks. Despite that, we still have lower rates overall than those two areas. Where we are with the lockdown is nationally, we are starting to see a flattening out of the rates of infection across the country. That's, again, we suggest and suspect, due to the fact that large parts of the north of the country, the northwest of the country, have been in higher tiers, tier 3 interventions for a number of weeks. And that will have been playing through into the figures in advance of the lockdown. For Lincolnshire, we're still seeing an upwards trend in our data. I would expect that to continue probably for the rest of the week and even into next week, before I would hope, and obviously we keep a very close eye on the data, to see that starting to level out and then hopefully start to come down towards the end of lockdown. Whatever the direction of travel is at the end of lockdown to the beginning of December, I would expect to carry on for a period of time afterwards, given the natural history of this disease. So hopefully, if on the 2nd of December we're on a downward trend, then I would expect that to continue down for maybe a week, 10 days after lockdown is released before it'll start to flatten. And I do expect it to go up again, but hopefully we'll have brought it down. Lots of questions I'm sure people might want to ask around things like the vaccination programme, around maybe some of the announcements around the university test and trace model. I won't go into any of that in detail because I think it's better to allow members of scrutiny to ask those questions, and I will answer as well as I can do. So in terms of an update, that's as much as I'll plan to do, apart from pointing members to the paper that we pulled together as well.
Thank you very much for that. Okay, Councillor Whittington, I have first, please.
Thanks, Mr. Chairman. Thanks, Derek, to report and your speak. Yeah, I think since one of the things I find most frustrating about this wretched disease is that there's been sort of indications over the last sort of reports in the press over the last sort of few days that people think that the infection rate is actually dropping, and the R rate may be approaching 1 again, and then yesterday it was the highest number of deaths since May, because obviously there seems to be this 3 or 4 week lag between an increase in the number of cases and then sadly the number of deaths. But what I want to talk really about is the sort of is the mass testing. Obviously, it's been currently piloted in Stoke, I believe, and Liverpool especially. In today's Independent, there's a whole list of areas that potentially where mass testing could go to next, and they are the areas in the north and the big cities and whatever. And Lincolnshire's not on that list. So really, the question is: do you think at some point we will have a? And obviously, obviously, because our rate is lower than other parts of the country, do you think at some point we will get mass testing? But would it be a case that because our rates are lower, we're likely to be more towards the end of the queue than the beginning of the queue? And then secondly, once we get the vaccine. I mean, I read today that they're hoping to get the first sort of people being vaccinated early part of December. I think in today's Telegraph they said the 1st of December, but obviously they're still awaiting the results of the tests coming out, the safety tests. But once you get the vaccine in place, and I know the government have got lots of criteria. There's lots of criteria around the tiers in which people will receive it first. When it's rolled out, will the vaccine go to those areas with a higher R rating first, or will it go out? Because I'm just thinking that we've probably got people as vulnerable as, say, people in Liverpool, and I'm just wondering, will it go on areas that got the higher R rating first, or when the bans are looked at, will it be, well, if we're doing care home people first, will it care home people in Liverpool at the same time as be care home people in Grantham or Lincoln? Do you understand what I'm saying there? Yeah. Thanks.
I do, Councillor Whittington. Thanks for your questions. I'll cover the mass testing first. The expression of interest that came out from the government specified that it would only be for those areas with very high prevalence in the first instance, which is why Lincolnshire isn't on that list at the moment. We are in conversations, I am in conversations, and have been all of yesterday with regional and national government to talk about where and how those tests could be deployed. I think we need to make a distinction between what Liverpool are doing, which is a mass test, with what I think we could do in Lincolnshire. I'm very interested to see what happens in Liverpool, both from a professional perspective and as my hometown. But I think mass testing isn't the way to go in Lincolnshire particularly. I think what I would prefer to do is have a very targeted surgical approach to our testing regime. At the moment, we can only test where somebody is either symptomatic, or where we have a national scheme in place, for example, in care home testing, where we can test asymptomatically. The benefit of what is called the lateral flow test is that it may allow us to test asymptomatically a lot quicker and a lot easier, but there's still lots of questions about the efficacy of that particular test and how to deliver it, so we're in conversations with those. So that's the testing regime. I would like to be able to test a lot more in Lincolnshire. The lateral flow test may be a really good solution to do that, but I'd want to target that on asymptomatic people, and I'd want to be able to be very strategic and surgical about who I want to test, and it will probably be close contacts of existing positive cases. In terms of the vaccine, it is being led through the NHS, so a lot of those questions would be for the NHS to answer, and I'd suggest that maybe that could be an agenda item at next scrutiny. What I can say is that my understanding at the moment, and we're working very closely as you would expect, is that the rollout will be by priority groups. The two first groups will be residents and staff in care homes, and will be NHS frontline staff. And that will happen across the country at the same time, obviously depending on how much vaccine is available at that point, and which vaccine is available at that point. So all of that is, we'll find out, as you would expect with what will be a massive undertaking. We're doing a huge amount of work on that at the moment to be ready. I'm confident that Lincolnshire will be ready to roll it out when we start to get some of the vaccine, but I expect we'll get relatively small amounts at the beginning, and then it'll crank up.
Thank you, Derek. Obviously, in Lincolnshire, we've got a lot of RAF personnel. I'm just wondering if for some time the government, obviously using the army at the moment, might decide at some point in the future to make use of the other armed services. Thank you.
Certainly armed service personnel and the conversations are ongoing through the Lincolnshire Resilience Forum, but it would be in what capacity, because it's not just obviously delivery of the vaccine. Well, it's delivery in a number of ways. It's the logistics of getting a vaccine or vaccines across the county and around the county, and that's where it may be that Army Logistics or Armed Services Personnel Logistics Corps could help, but that's ongoing conversation, and we'll continue those conversations.
Thank you. I do have 4 more speakers, and I would like them to have the opportunity to ask questions as possible. So if you can keep them succinct and concise, please. I have Councillor Brewis next.
Thank you very much, Tim. Amid the celebration about the possibility of a vaccine, and I have to say that this is far more serious than the fatal case of pneumonic plague in the village I lived in the 1960s. I see today in the papers that they're suggesting GP services will be cut back to allow millions to receive the COVID vaccine. What are the long-term implications of that? And what really frightens me is, if we are making vaccination voluntary, with the amount of fake news around, which is blaming everybody from Bill Gates to Nostradamus trying to get his revenge, are we frightened that the proportion of people who, with it being voluntary, will actually volunteer to be vaccinated? And are we actually coming to the stage where we're going to have to get used to this coronavirus being around for perhaps a decade?
Thank you, Councillor Brewis. In terms of the impact on the NHS, that's clearly it's more of a question for the NHS, but it will be a balancing act. And I think Councillor Whittington's point about using wider personnel and trying to make sure that we have to be able to continue with the fact that the NHS is open for business, and that's a really important message. People need to continue with their existing treatments, as you know, the rest of Scrutiny have heard throughout this meeting. Huge amounts of progress in terms of NHS services and delivery, and that will continue. At the same time, we've got to roll out a huge programme of vaccination, and that all of those conversations are ongoing. I would not expect a massive impact on the NHS. It will be a very managed change in service delivery models. clearly, as it's a brand new vaccine and it's gone through all the appropriate trials and testing, we need to make sure that it is at first at least delivered by clinicians so that they can help with any what will be very, very, very rare adverse reactions from what the vaccine looks like at the moment. But we need clinicians on hand to do that. The simple message is, when the vaccine is available, I am absolutely sure it will be safe and it will be effective. And everybody who is offered it, my advice would be, go and get the vaccine. It is another tool in the toolbox that will help us get on top of COVID. I think your point about this virus being around for a long time is absolutely right. It will be. It's a coronavirus. A chunk of the different viruses that cause colds are coronaviruses. We have a whole range of different coronaviruses. That's not the issue, really. It's about having a suitable vaccine. It's about the population having immunity because they've been exposed, and then it's about having good treatments. And all of that is developing. The science is developing very, very quickly. So the fact that COVID will be around for a long time is not a major concern, really. It's about getting the right people vaccinated, but ultimately making sure that everybody in Lincolnshire sticks by the key rules. So that's the hands, face, space message, because that's the way we stop onward transmission.
Thank you very much. If there's anything we can do as individuals, for heaven's sake, let us know. Thank you.
Certainly will. Thank you.
Thank you, Chris. Okay, I have Councillor Renshaw next, please.
Thank you, Chairman. Well, it's back to the hands and the space and the face. When I take my exercise, I'm alarmed at about the 50% of the population have got a cavalier disregard for social distancing. We might as well not bother, because they're just ignoring it. And my obligation to meet with that is, when I'm walking on the footway, is to walk on the verge or on the road if it's safe to do so, because people are clearly not going to move and give people space. I mean, lockdown is constantly ignored, and to the local community just carries on normal as regular, mixing glibly with non-family members. And school leaving times are a classic example of this. You wouldn't believe that there's an epidemic current. We're somehow not getting the message across to the general public, and I think that's because most of the general public don't necessarily listen to news channels like us politicians do, and so therefore they do not see the message. And the message they only see the news is what's been passed on by word of mouth or social media chit chat. And I think we've got to reinforce that message, and I'm sure Derek would agree with that. Thank you.
Thanks, Councillor Renshaw. We've absolutely had a very active communications programme through both the County Council and through the wider partners through the Lincolnshire Resilience Forum, including Twitter feeds and Facebook feeds, Facebook Live. So we are absolutely trying to engage with as many different sectors of the public as possible and get those messages out. I guess it would be interesting, and I'm sure we'll find out over time, just how many people don't actually know the hands, face, space message, as compared to how many people maybe don't take it as seriously as they should. But all we've got to do is look at the overall number of deaths in the country to understand just how seriously we should take this virus.
Thank you. Councillor Cabry Brown. Councillor Cabry Brown, is it a question you wanted to raise or not? Okay, in which case I will move over to Councillor Hedendrick.
Thank you, Chairman. Morning, Derek. Just something I'm just wondering about is in relation to the issue of mask wearing. Is there much empirical data on how it reduces transmission rate? I did recall at the start of this whole business, Jenny Harris, one of the deputy officers, said at one of the press conferences, she or was reported to have said, she wasn't terribly concerned about the need to wear masks, and then that obviously changed and became policy. Bearing in mind we've had an increase in transmission rates, whereas hopefully most people have been sort of wearing masks, it seemed a contradiction that the rates have gone up and yet mask wearing has become obviously the prescribed thing to do. So I'm a bit confused. Surely they should have actually been halted earlier or reduced because of mask wearing. I'm not quite sure what the data is on or what the evidence is that has been an effective measure in reducing transmission rates.
Thanks, Councillor Kendrick. The evidence is developing as we go because obviously, as we know, this is a brand new virus. We've only had it around, well, we haven't had it around for a year yet. So we are understanding as we go. And Jenny's Deputy CMO advice in the early days was a conversation we were having with, as Director of Public Health, with the CMO's office. One of the risks with face masks, and I'll make a distinction here, with face masks is that people may not doff and don, put them on, take them off properly, and therefore they could risk having the virus on the mask, put it on the fingers and then catch it anyway. So that was part of the reticence to have a whole scale adoption, because it's not something that the general public are used to doing in this country. So that's point one. Point two was, at that time, obviously, personal protective equipment with the beginning of wave one was a problem. So that was another issue. And thirdly, there was a concern that people who might wear a face covering would think in some way that was a superhero shield and they would never need to do anything else, and that's clearly not the case. It's hands, face, space. There are multiple, you can get it from somebody coughing and sneezing, but you can also pick it up, and if you touch your eyes, your nose, your face, then you will pass it on. So there was a whole raft of reasons why that was a debate, and other countries went different ways, and that will all be reviewed. I think where we are now is that face coverings, which are the things that you or I would wear when we go into a shop, they're not protecting us, they're protecting other people. And obviously, the more people that wear a face covering in those environments, we're protecting each other and therefore bringing the rates down. And we saw through the summer, after the peak of wave one, we did come down and we stayed down. But with winter, people staying indoors more, more other diseases around, we've seen the steady increase. So I think the two are separate. I think the bottom line is that face coverings, when we wear them in an enclosed space, protect other people. There's no question that's true. How much they protect other people as compared to other measures is why we keep the space. My message is always keep 2 meters. I know you're allowed to do 1 meter plus. Keep 2 meters if you can. Why wouldn't you? It absolutely reduces your risk. And make sure you're not touching your nose, your mouth or your eyes when you're out. Wash your hands properly. And if you don't have access to hand washing facilities, then it is about using an alcohol gel in the first instance.
Thank you. Thank you, Chairman.
Thank you. Councillor Fido.
Hello. I had to actually change offices, so forgive me if somebody's briefly touched on it. But do we have any statistics on the take-up rate of Lincolnshire residents of the NHS track and trace app? I know that, for example, in my day job, I'm being very sort of forceful in now allowing people into our office unless they've got pre-arranged appointments, at which point they have to wear their mask and sign in on that. And there's still an alarming number of people who say to me, oh, I haven't got the app. And I'm saying to my colleagues, well, people signing a bit of paper, it doesn't actually do anything. It's not worth the paper they're written on, because how are we meant to protect our staff members by knowing if someone's had a test in the subsequent few days? It's only through, the contract tracing and proper testing that we're gonna beat this virus, isn't it?
It is. Thanks, Councillor Fido. Really good question. I think it opens up a much bigger debate. Short answer is no, we don't know how many people in Lincolnshire, residents of Lincolnshire, have downloaded and used the app, because it is, by its very nature, anonymous. What it does is, as you know, use background Bluetooth low-level technology to trace anonymously and alert people anonymously. I think it brings us on to the conversation of the National Test and Trace Programme, because that's the other key plank of the model. And obviously, where we are now, as we go into a lockdown, one of the conversations we're having is with national government about how the future model, what the future model might look like when we come out of this lockdown. My preference would be we have a lot more ability to follow up new positives and actually backwards contact trace, because my team, we're very fortunate in Lincolnshire, thanks to the investment that the county council's kept in public health, that we've got a dedicated health protection team. They've been helping advise schools and care homes, but we want to be able to follow up our positives, because people who are followed up by a local Lincolnshire number, by people who understand Lincolnshire, are more likely to respond and therefore isolate and also tell us about their close contacts. We can then potentially use more follow-up methods to try to stamp out and keep down the rates as we come out of lockdown. But they're still early conversations with national government.
Can I ask a very, very brief follow-up question, if that's okay, Chairman?
Yeah, as long as it's quick, because I'm just conscious Derek needs to be away for one.
Okay, it's just a quick one in the sense of when we talk about the contact tracing process. So people have phoned up and asked where they've been, who they've been into contact with, and things like that. In my industry, in the housing sector, we are still trying to stay open and have appointments, but by following all the rules. Isn't there not a risk, without people using the app and doing it properly, forgetting about maybe a 5-minute trip to the estate agents and potentially putting, entire industry at risk and things like that? Just to use my industry as an example.
Yeah, the national model is not as you just described it, unfortunately. The national model is that you get confirmed positive, you are contacted by test and trace, and obviously some of the challenges nationally are about the percentage of people that are being contacted, and then you are asked to enter on a website, generally as the first port of call, the close contacts, and there is a definition of what close contact will be, onto a website, and then they should be contacted by the national system subsequently. So it's all done remotely and it's not done in Lincolnshire, and that for me is part of the challenge and part of the learning we've had over the past few months is what we could do in Lincolnshire is quite a lot, but we need the tools and the permissions in place to allow us to do that. So it's a bit more nuanced than that, I'm afraid. The model you're describing is exactly what we would do, except we would do it fully as we would do before COVID, if anybody can remember that time. If we ever had an outbreak of tuberculosis or meningococcal, we would, through my team, follow that up in detail, and we would phone people and we would go through them or even go face to face, so that they could remember. And there's techniques that you can do to backwards contact trace, so we can help people remember where they've been. We can gently, supportively probe them so that we understand exactly who they've been in contact with and whether that would meet the case definition of a close contact, and then we follow them up directly. That would be the ideal, but of course there's lots of resource and challenges in line there, and that's part of the conversation with the national government.
Okay, thank you very much for that.
Thank you.
Okay, I'm going to move to a proposal now. So I'd like to thank the Director of Public Health and take him up on the offer of a further update in December on the vaccine. And thank you for your patience with us. I know we've gone over, so thank you for that. Do I have a seconder for that proposal, please?
Happy to second that, Chairman.
Thank you, Councillor Brewis. Once again, we will take this on dissent. So if there is any dissent, then that will be carried. Is there any dissent at all? No, in which case that's carried. And once again, thank you, Derek. We'll look forward to your next update. We'll now move on to agenda item 8, the Louth and Skegness Urgent Treatment Centres, which is page 83 and 84 of the agenda pack. Simon Evans, over to you.
Yes, thank you, Chairman. This item picks up the earlier item on the agenda and is basically seeking the committee's decision on making arrangements to respond to the Louth and Skegness patient survey, the Louth and Skegness Urgent Treatment Patient Survey, which is still open, but is due to close on Friday of this week. So it's basically seeking a move forward. One option would be to for the committee to authorise the chairman to reply on the basis of the comments earlier this morning and any other comments made under this item in relation to this patient survey. Thank you.
Thank you, Simon. Yeah, I don't plan on taking any more talkers on this. We've obviously gone over this earlier on, so I'm just going to go straight for the proposal. And my proposal was that I be authorised to write to Lincolnshire Community Health Services NHS Trust, expressing the view that the changes to the opening times at Louth and Skegness urgent treatment centres should only be a temporary measure during the COVID-19 pandemic, and there should be an aim to reopen these two centres in the longer term on a 24/7 walk-in basis as set out in the Healthy Conversation Engagement Exercise of 2019.
Happy to second that, Chairman.
Thank you, Councillor Brewis. I think on this one we'll have to go to the roll call, Simon, is that correct?
Yeah. Trina, could you just advise, because the wording of that is very similar to the earlier, it's really, I suppose, the crux of this is the authorising the chairman. Could this be done by dissent, or does it need a roll call?
My view is we could probably do it on roll call as long as we find out if anyone, has got dissent or is against it. I think if that's clear, Chairman.
Okay, that's fine. In which case, we'll do it on the dissent basis. Is there anyone who dissents from that proposal? No, in which case that's carried and that submission will be made. Thank you. We'll now move on to agenda item 9, the work programme. Simon.
Thank you, Chairman. This is the standard item which sets out the committee's items for subsequent meetings. We have had an addition to the December list following the last item. I would also say that unusually in this item there is a specific request to consider whether the committee would like to include NHS continuing healthcare in the committee's work programme. There is information in the paper on background information on the topic of continuing healthcare, and there was also additional information relating to a report from the Parliamentary and Health Service Ombudsman, which was published recently, which was in your supplementary announcements emailed to committee members yesterday. So there's just two parts to this item. Thank you.
Thank you. And of course, there was a few things raised as well, Simon, over the course of the meeting. I think Councillor Bruce wanted to see an update on the UTCs in the southeastern part of the county.
Yeah.
So if that could perhaps be added as well. And of course, the committee's view on what Simon has raised. Councillor Harrison.
Thank you, Chairman. Way back 2 or 3 meetings ago, when we were looking for items for the committee to do in their work programme, I mentioned about use of opioids. I still think it would be an important issue because Connect Health are supposed to be reducing the level of opioid use within the county. That's one of the things that they're supposed to be doing. There's never been any mention when they've done a report about that. Only satisfaction of users, nothing about the impact on the use of opioids.
Yes, I think in our next update with Connect Health, that is something that we can include in that report. And I'm sure that Simon and I will pick up on that in our pre-meeting when we speak to them on the subject. Thank you. Councillor Brewis, you'd like to come in?
My hand was left up, it's come down now, sorry.
Okay, thank you, Councillor Brewis. Councillor White, you've suggested that Derek Ward comes in at a time close to the ULHT COVID update in December. It will be if we take it as December. We'll make sure that that it follows on in that manner.
Thank you. It seems sensible. Thank you.
Okay. Any other questions or points or anything that would like to be raised? No. In which case, are we happy to also take into the work programme the supplementary announcements provided on the recent publication by the Parliamentary and Health Service Ombudsman, as Simon has alluded to? Again, I'll take that by dissent. So I will accept that as well. Okay, in which case, I think we've covered all actions. Simon, are you satisfied with those?
Yes, thank you, Chairman.
Thank you.
Yeah.
Okay, well, that brings the meeting to a close. I'd like to thank you all very much for your contributions today, and hope that you all keep safe and well, and look forward to seeing you soon.
Thank you. Bye.
Thank you.